Welcome to the Pro Transport Clinical Education for Advanced Airway Management for CCT. Today we're going to be going over anatomy physiology related to advanced airway management, transport considerations for airway management, current concepts and trends that are happening in emergency medicine in the transport world, clinical decision making that you'll need to make in an ambulance with your patients, different pathways of management for airway emergencies that may happen on the ambulance, and we'll be reviewing all the standardized procedures that occur with our medical director oversight. You may be thinking of being a little apprehensive about airway management in the ambulance. It can be a challenge, but with vigilance and monitoring and the skills that we're going to go over with you, you'll be able to master those skills and provide great level care to our patients. Just a quick disclaimer at the beginning of the course, our medical director at Pro Transport, Dr. David Wolf, manages Northern California operations. The course and the skills that we are reviewing today are for Pro Transport CCT only. Not sure who may be watching this educational video, but it's important that you review your program, clinical skills, practices, and standards. Not everything that's reviewed in this course will be approved by medical director for your program or our program, but we are reviewing all the clinical skills that a practitioner may encounter during CCT operations. My name is Steve Crabtree. Although I have the gray hair to prove my experience, I'm not going to go through all the details, but my background is hospital. I've worked in the emergency room, various critical care units. I've spent the last 18 years on air medical and ground critical care operations along with EMS experience. Again, our medical director, Dr. David Wolf for Pro Transport. His specialty is anesthesiology. He's based here in Sacramento and Carmichael, and he's affiliated with UC Davis and Dignity Healthcare. We've got some great pictures on your PowerPoint of his last airway education. And then a special mention for clinical support with Rob Smith, our clinical director, and Catherine Fish, our CCT manager. So at the beginning of the course, you may be thinking, what exactly are we going to cover? And you may be, again, apprehensive or a little bit nervous about the skills that we're going to introduce today. And you may reflect on difficulties you've had in your clinical practice or airway emergencies that you may have encountered in your experiences, or maybe you've had bad intubation experiences. So reflecting on all that during the course, we will go over those challenges and give you the tools and the skills and how to meet those. This picture that you're looking at on the PowerPoint is my very first intubation as a registered flight nurse. This is back in 2005 with a 22-year-old female that was ejected from a motor vehicle accident on the roadway. I'm laying on my stomach. I'm trying to get this poor girl intubated with massive facial and head trauma, and my paramedic partner just happened to snap this picture as it was my very first intubation. But looking back at this now 18 years ago, and the blood smeared on my face and the intensity and the fear that I was having, taking responsibility, pushing those meds, getting the patient intubated, a lot of those things can be overcome in the ambulance with your education, your skills practice, and the confidence that hopefully we'll cover today in the course. Common comments that I encounter frequently when I cover advanced airway management courses and ground CCT or even air medical sometimes. Why do we need to learn this stuff? It's another training course, but I'll never need to intubate someone. We only transport stable patients. I'll never be involved with skills like these. Or my favorite is I can just pull over and call 911 for an ALS backup to come and help me out. We hardly ever transport emergency patients and take stat call requests. It rarely happens. Or I'm always very careful. I've never had an ET tube come out in the ambulance. Or I can just always divert to the nearest ER. What we want to emphasize with the rollout of the Advanced Airway Management Program is minimum safe standards for our nurses. The different counties that we operate in, the expectation is we are meeting minimum levels, which is basic ALS level care. That is the standard. The expectation are the nurses are able to intubate, the nurses are able to run a complete cardiac arrest call independently. In every county, if there's a registered nurse on board, CCT is considered a higher level of care over ALS, and that's the expectation. So back to minimum safe skills. what has 18 years of flight nursing taught me now that I've been in the game for a while? Patient outcomes in an emergency during a transport becomes completely dependent on the crew's knowledge, experience, and self-confidence, and mostly their self-reliance on taking appropriate actions. It's the nurse's decision-making and the crew's actions that can make a huge difference. And that's why we really want to emphasize the skills practice when you have those opportunities and taking the time to really advance your knowledge base. It's an individual responsibility, and your patient outcomes can reflect that. So a little bit more on the objectives. We'll focus on patient assessment, again, the clinical decision-making, those minimum safe skills for the transport environment for the registered nurse, and in rolling out our standardized skill procedures. So let's talk a little bit more about the standardized skills that we're going to be having. Again, minimum safe standards for every county that we operate in is a registered nurse must be able to intubate a patient, including adult, pediatric, infant, and neonate. Several EMS counties have implemented a restriction for pediatric intubation, so many medics cannot even do pediatric intubation in their areas. However, a registered nurse for CCT or flight is able to do pediatric intubations. We're going to roll out the bougie or flex guide introduction. You can use that as an introducer or an exchanger for an endotracheal tube. Let's say you're on a critical care transport with an intubated patient and you have an intermittent end-tidal CO2 waveform. You're not sure what's going on. You can visualize your airway. You see your tube is partially in or out. Bougie is a great way to do a tube change out in the middle of an ambulance transport. iGel airway insertion as a rescue airway. Needle thoracostomy, tracheostomy, emergency management. So we're gonna go over what to do for those trach patients if you have a tube dislodgement, the intercannula becomes obstructed, you're not able to ventilate a trach patient. How are we gonna manage that in the ambulance? Video laryngoscopy, we're gonna introduce the Vivitrax system, which is a disposable video laryngoscope in adult and pediatric that allows you to go in and visualize the airway for intubation and for checking tube placement to see if the endotracheal tube's actually in the upper airway. Then we'll move into rapid sequence intubation. Cricothyrotomy, when we have a failed airway, we're going to end up needing to put something through that cricothyroid membrane. So it's either going to be a quick trach device, needle jet insufflator, and we will cover surgical airway. And again, not all the skills that we're covering today are specifically approved by the medical director. We're still sorting out which ones will be the best. However, we're covering all of the skills so that the nurses know what the expectations are if you might be assisting or what might be happening if you find yourself involved with any of these procedures. And then the quick trach device we're introduced is actually called the Quick Trach 2. It's very nurse friendly. It slides right into the cricothyroid membrane and threads off like an IV cannula. We're going to go through and discuss all of these skills. We're going to demonstrate the skills for you so everybody's thoroughly prepared for the skills day with the medical director. Again, not all of the skills are approved by the medical director at this time. We'll have the skills and the protocols ready to go for your skills day. And again, it's the RN's responsibility to know what the expectations are and again, the knowledge of what all the skills are. If you find yourself in the emergency room and you're getting ready to transport a patient that suddenly needs an emergency cricothyrotomy and you're the nurse standing at the bedside, our expectation at Pro Transport is that you will assist that physician. You have the knowledge of what's going to be happening, the equipment that's going to be needed, and we would encourage you to help assist with patient care. If you're ever in the middle of a deterioration and you're a little hesitant, we would encourage you to always do what's best for the patient, assist the staff, even if the point occurs that you don't end up transporting that patient. For clinical decision-making for critical care nurses on the ambulance, not all patients fall into a black and white category with our protocols. There's a lot of gray area, and that's personally why I love CCT and flight nursing. There's a lot of protocols that are open to interpretation in your clinical practice. Many times we find ourselves just over the line in a gray area. With airway management, you can frequently run into those situations. And your default guidance should always be to do what's best for the patient. The medical director, management, Rob, Catherine, any clinical educators, nobody will fault you if you're always doing what's best for the patient, operating in those gray areas. Clinically justify your decision making and why you did that. A little bit more, we'll discuss common clinical mistakes that can happen with CC2 nurses in the back of an ambulance. Identify appropriate airway management interventions that might be more patient or condition specific. How to plan for a difficult airway. How to plan for a double setup if you can anticipate you're going to have a difficult airway, and then anticipate potential problems that can occur in airway management in the back of an ambulance. As with any medical lecture, we'll go through just a quick anatomy review, although this obviously would be a review for many people. I really want to emphasize several anatomical structures that are critical for the nurse to know that's going to be intubating. So those structures are the posterior oral pharynx, the larynx, the epiglottis, our thyroid cartilage, cricothyroid membrane, and the cricothyroid cartilage. It's absolutely imperative that you understand that anatomy. As we review the skills and we're discussing moving the laryngoscope down through the airway and placing your endotracheal tube, we're emphasizing the anatomical structures and what you're looking for as the blade is advanced. So it's absolutely critical that you understand the anatomy and those structures. We'll be talking about looking for the structures as you get into the airway. Never insert a tube that doesn't have, in a hole that doesn't have structures around it. We're looking for those cartilages, the glottic opening, and the esophagus is just smooth with no structures at all. On the anterior anatomy of the neck, we're looking at the thyroid cartilage up at the top and the cricothyroid cartilage at the bottom. So what I wanted to point out with this slide is the middle cricothyroid membrane. As you can see, it's a very safe membrane to do interventions in because it's surrounded by a cartilaginous ring. So when we introduce a quick trach or surgical airways that happen there or jet insufflator, there's really no risk of lacerating the trachea or doing any kind of transection. There are small vessels there that bleed a lot. However, there's no major arteries in that area. So cricothyroid membrane identification, again, is vital for a failed airway and the interventions that go along with that. Getting more detailed into the airway anatomy, this slide represents what we're looking for when we get in for laryngoscopy. We're looking for the epiglottis, the horseshoe shape up at the top. We're looking for the cartilages at the bottom, interarytenoid notch, and that glottic opening looking right at you with the vocal cords. Another view, I especially like this slide as it shows the base of the tongue. The epiglottis is situated right at the base of the tongue. So as we're inserting our blades, we can come down the back of the tongue. The epiglottis at the top should start to come into view. And then depending on which blade you're using, if we're sliding a Mac blade into the vallecula, then the epiglottis can snap up into place and bring the airway anatomy into view. Again, emphasizing the structures that are around the airway, that glottic opening. You can see the arytenoid cartilages that are there. And at the very bottom, we're looking at the esophagus that is smooth. It's a smooth, black, open hole. It can be misleading at times with different tissues and ligaments coming down the sides and may look like structure. That's why it's important that you burn the airway anatomy structures in your memory and you know what you're looking for during an intubation attempt. These are real-life views of the airway that we're discussing. At the top left, we're looking at an adult airway. Again, the arytenoid cartilages are visible. We've got a great view of the glottic opening, and it's actually looking down the trachea. You can see the cartilaginous rings of the trachea as we look down. At the very top, you can see the top of the epiglottis there. The bottom right on the slide is a pediatric patient. You can see how that glottic opening is much smaller. The epiglottis is much larger in relationship. And again, it has structure around the hole. That's the vital thing. And you can see because of the size differences, why it's absolutely vital that you're using a Broslow or a PD tape of some type to get the weight-based size for the endotracheal tube. I know there's several different formulas. However, in all of my practice, and I strongly recommend, use a tape-based reference. Do not try to do any kind of manual calculations with pediatric or infant patients. Again, emphasizing anatomical structure is a vital to success in airway management. You're knowing what you're looking for and what to expect as you get into an airway. The reason why we emphasize that is you're going to encounter the unexpected. Here's some ideas of what you might encounter. The slide to the left, we have severe tonsillitis with airway involvement extending up into the hard palate. You can see the view would be obstructed with any type of laryngoscope blade. It's going to be very hard to get a tube clearance through there. The upper right, paratonsillar abscess, which we commonly would see in the emergency room. This one's gone on for a while. The airway's almost 75% obstructed that we can see into the posterior oral pharynx. You can imagine that that's going to cause a lot of problems if you're trying to get in to do airway management. And then the bottom right is epiglottitis on an infant. And this one is especially scary as we can see the infection has involved a good portion of the airway, with the airway just almost completely occluded. And you may think to yourself, I don't think I'm ever going to encounter anything like this, but this is completely in the realm that you could be dispatched to one of our rural facilities in the surrounding areas. They've got a patient such as this that needs to get to a higher level of care, and you're the mode of transport. Maybe the ER is uncomfortable intubating the patient. They don't think they have the skills, and you get a patient like this on board your ambulance and they have a deoxygenation or an obstruction or an airway event that you have to intervene on. So it's completely in the realm of possibility that you can transport these patients. Here's another great view of why anatomy is important. This is a cardiac arrest patient secondary to a gunshot wound. As you can see in the airway, we've got a lot of emesis, blood, there's tissue and debris in the airway. However, you can see the endotracheal tube going through the glottic opening. We can just make out some of the rytenoid cartilages, and the epiglottis is not in view. You can see the pale tissues from the lack of circulation, but again, you're looking for those structures to assure tube placement. So we've gone through these kind of dramatic photos. We'll show you a quick video of what a normal intubation looks like in those structures. The nurse is progressing the blade down the tongue. We're encountering the tonsils. This patient has a cryptic tonsillitis with the inflammation of the tonsils that are chronic. We're moving into the posterior oral pharynx, and then we've got a great view of the airway. The nurse has moved the blade up into the vallecula. They've identified the structures. We're advancing the bougie through the glottic opening. Fantastic view. We can even see down into the trachea with those cartilaginous rings. Advancing the ET tube over the trachea with the markers going just past the glottic opening. Great visualization of the airway during this. And then they slowly pull the blade back out, watching the tube seat into position. So that's a great intubation, great example of the anatomy and the visualization of that. All right, so airway management algorithms. I'm going to introduce some algorithms, and rather than standard EMS algorithms that deal with emergency airway management and just basic level, this is what you see, this is what you do, we're going to introduce what the emergency physicians are trained with. And Dr. Walls is one of the airway gurus in the nation at the time, and he has a series of algorithms that many ER physicians and advanced practice nurses go through in order to learn advanced airway management. So that way you'll have the knowledge of what their line of thinking is, and you can kind of follow those same pathways. Two important questions to ask whenever you're in an airway emergency or in an airway management situation. Is my patient oxygenating well? And are you being forced to act by circumstance or any clinical findings? If you're being forced to act on what's happening with your patient, it kind of ramps up your anxiety. It's going to cause you to react more quickly Whereas if they're oxygenating okay, it may buy you some time for clinical decision making and kind of work through some algorithms and figure out what you might be able to do. One thing to reference here is distractions. So in flight, we would commonly train new flight nurses that you'll encounter trauma patients that have distraction injuries. Same thing with CCT. You may pick up trauma patients when air's grounded or do interfacility transports where you've got distraction injuries that can take you away from clinical decision making. This can be especially true if you have an airway that's starting to go bad, your patient's desaturating, all the alarms are going off on the monitor, suddenly you're upgrading to code 3, the siren's going off, the ambulance is flying all over the place out here on Interstate 80, and your clinical judgment can become altered. So it's important to separate yourself from distractions, whether with the patient or from the environment, so that you have sound decision making in your airway management. Part of that is, moving on to the next slide, is a clinical timeout. In the ER, we would frequently do that in an emergency. Just everybody regroup, take 1 second for the group and discuss, okay, this is what we're going to do. This is our plan and this is how we're going to get there. One thing that we'll emphasize here at ProTransport on CCT is the use of a procedure checklist. So in your airway bag, there'll be a quick checklist that you can go through. Just take a quick, brief timeout, make sure you have all your equipment, you have your backup plan, and everything's laid out ready to go before you start treatment on your patient. We have a reference card for RSI and medication administration, and it's especially important that you're using a reference that we provide you for your medication calculations, especially with pediatric and infant patients. Don't try to do manual calculations in an emergency. Those can be very troublesome and produce anxiety and stress. A best practice with any CCT transport would be to know the color of your Broslow tape for your pediatric patient and have that written down somewhere ready to go. So if you have an unexpected emergency, you know exactly what color to go to. You're not fumbling with the cards trying to measure from the head to the feet. What weight are I can't remember what's happening, and it adds a whole layer of complication to your transport. The other thing in most pediatric centers is with infants and pediatrics, they will print out an emergency reference sheet and usually tape it to the outside of the room. When my daughter was at Valley Children's Medical Center, that's exactly what they had, an Isabella Crabtree sheet posted up on the wall, and it had everything listed that you would see on a Broslow tape. So after recognizing that, talking to some of the staff, we've just been taking those on those pediatric transports. So ask for that emergency reference list they've already printed out. It can be a great resource for you. The next slide is the ProTransport RSI reference card that you'll find in the Airway kits once we implement all of this. You'll see in the center section it talks about the 7 Ps of RSI, which we'll be reviewing in detail today. It gives weight-based medication dosing and volume, so it takes all the guesswork out of an emergency. Find your patient's weight, follow the lines across, it gives you everything that you need to do. I love the slide that you're looking at with the blue background. It talks about the transport nurse's heart rate in relationship to what's happening. So you can imagine, you start off with your first laryngoscopy attempt, your heart rate's normal, and then you realize that you might have some airway problems. You make some changes, you go back in for attempt number 2. Now maybe the patient has emesis and the suction's not working right, and now you're moved on to attempt number 3, and your heart rate's starting to go up. So as you reach the LMA insertion or the iGel insertion, the nurse's heart rate is well above as the patient's heart rate proportionately is falling as the patient goes into cardiac arrest. So that pretty much sums up a really, really bad airway for people that are unorganized and not skilled practiced and not prepared. Don't be those nurses. You don't want to fall into that trap. Rapid assessment for airway emergencies and any kind of airway management. You should be thinking this clinically with your patient in the back of the ambulance. Can the patient maintain their own airway? Can the patient protect their airway? Is the patient appropriately ventilating? Is the patient appropriately oxygenating? Is the patient's condition likely to deteriorate? And what's the anticipated hospital course? If any of these questions are answered where you're not sure or doesn't look like they are oxygenating or ventilating well, then your treatment course is going to end up probably being intubation. There's a lot of emphasis that's placed on GCS less than 8 intubate. So in case you're not up on the history of GCS, that kind of started back in 1973 when they were doing studies on trauma patients and head trauma patients specifically. And they found that traumatic injuries to the head, if the patient was 8 or less, would most likely end up in an intubation. So it's kind of carried through the years. And for the most part, the majority of our patients are medical patients. So it's a little more subjective, and you may have a patient at 8 that may not need to be intubated. You may have a patient at 7 that responds a little bit that may not be intubated. However, the general rule of thumb is if you have a clinical deterioration with a patient that's gone from like a 9 to an 8 to a 7, then you're most likely going to end up in an intubation scenario. So just kind of be aware that the GCS less than 8 was more geared for trauma, but still kind of applies in the medical realm if you put it in context with what you're dealing with. Again, I'll mention Dr. Ron Wall, since we're using some of his algorithms as a reference here for credit. There's 4 algorithms that we'll talk about today. His universal airway algorithm, the difficult airway algorithm, the crash airway algorithm, and the failed airway algorithm. These definitely apply to the transport environment. And again, we're reviewing these because we want you to know what the docs are doing in the emergency room. This is the algorithm they follow, what their expectations are, and we know how they're going to operate. One thing that he says in his course, a calm, methodical approach is the key to a difficult airway management. Conquering the chaos is half the battle. And now that I've been in this game for a while, I would wholeheartedly agree with that statement. All right, we'll move into the meat of this whole course here, the 7 Ps of airway management. So we're going to talk about preparing all your equipment and supplies, what's needed. The pre-oxygenation phase, again, which is vital in this whole situation. Pre-medication, paralyzing the patient with induction, placement of an endotracheal tube, proof of that placement, and then how do we manage the patients after we've intubated them. All right, so we'll review those 7 Ps, and let's get into the first algorithm from Dr. Walls here. This is just the general airway algorithm. So basically, the first question you ask is your patient conscious, near death, or unconscious? If they are near death and unreactive, you're going to move into a crash airway algorithm. In the crash airway algorithm, our patients, we are still able to ventilate them. We just haven't intubated them yet. If the patient is a predicted difficult airway, we move into a difficult airway algorithm, and we are prepared to move into a failed airway algorithm if we're not able to get the patient intubated. And then the final algorithm is just a standard RSI sequence for intubation. The important ones that we're going to really focus in on are the crash airway algorithm, the difficult airway algorithm, and the failed airway algorithm. Those are the ones most encountered in CCT operations. In the materials that you'll hand out, I know this slide may be difficult to see during skills day. We'll give a more detailed view of these algorithms. This is the crash airway algorithm. And again, I'll just move through this quickly. We'll get into more detail on the algorithms on skills day. For predicted difficult airway, so we ask ourselves, is the patient not able to maintain oxygenation or not able to ventilate well? And right at the beginning, if it's a difficult airway and they're not oxygenating well, we moved right into a failed airway algorithm. If you are able to ventilate the patient with a BVM, you may be able to put in a glottic airway and ventilate the patient for the pre-oxygenation phase. And if that's successful, you might be able to try an intubation attempt or move into a full-on RSI. If those are successful, then you just move into post-intubation management. If those are unsuccessful, again, we moved into our default failed airway algorithm. Our failed airway criteria or failed airway algorithm, my favorite part of this algorithm is call for assistance, because in the back of the ambulance, as you know, there's no code blue button that you push. The cavalry is not going to be coming It's completely dependent on your knowledge, your comfort level, and your skills practice and what the outcome of this patient's condition is going to be. So a failed airway is when we are not able to ventilate, we are not able to intubate. We can try a glottic airway at the very beginning, although most of the time these are going to end with something being placed into the cricothyroid membrane, whether that's a surgical airway, a quick trach device, or a jet insufflator. So now, how do we assess for a difficult airway? What makes a difficult airway, and what are some of the tips and tricks that we can look at when assessing patients to figure out what those may be? On this slide, this is very pronounced. This is Ludwig's angina on a rather heavy gentleman. You can see how this would be just a real challenge for airway management with the amount of edema that's located below his chin. You can imagine what the airway structures are looking like and what would happen if you got in there and couldn't get this patient intubated. What would that look like trying to locate the cricothyroid membrane with the structures and palpating everything? It would be a real challenge. So for any difficult airway, you want to develop a strategy of how you're going to get the patient intubated, what devices you're going to use. Always have an alternative plan with a double setup. And what we mean by double setup is on a patient like this, if I was going to intubate, I would lay out a selection of blades. I would have the bougie out. I would have video laryngoscopy ready to go. And then I would have like a quick trach kit or some other cricothyroid membrane access device ready to go. On this patient, possibly 3 different setups for airway management in the event that we weren't able to ventilate him or we moved into a crash airway situation or a failed airway situation on a patient like this. Another quote from Dr. Walls that's really great. I can really relate to this in my clinical experience. The difficult airway is something one anticipates. The failed airway is something one experiences. If you're a 3 or 4 year CCT nurse and may not have a lot of emergency room experience or code blue experience, those of us that have experienced a code blue where everything just seems to go wrong, the responding residents can't get the patient intubated, the oxygen saturation keeps ticking down, and everything that you're doing, nothing is working. And then the patient ultimately goes into cardiac arrest. So that's why we're talking about all these situations today with our experience, the different tools that we have that allow us to mitigate and hopefully not get into those situations. Here's a great video on pediatric assessment for difficult airways and assessment findings. In the video that you're watching on the PowerPoint that I'm starting, listen for the stridor and then look at the different clinical findings on assessment with these kids. In the first one, you can hear a little bit of stridor. We're looking at sternal retractions and what that looks like. A lot of us read about these in our critical care books, and it's kind of hard to see it in real life sometimes, so this is a really great video. This is the seesaw paradoxical breathing between the chest and the abdomen. Now the child's work of breathing is really increased with the abdominal muscle use and that seesaw pattern between the abdomen and the chest. Upper airway obstruction with stridor. Stridor is always present on the inspiratory phase. Severe respiratory distress on an infant with the head bobbing. I would probably call that tracheal tugging also. And here's a great example of tracheal tugging in a child. Then full accessory muscle use, abdominal breathing on an infant having distress shortly after birth. You can note the acrocyanosis on the extremities. So for our NRP guidelines, this child's improving. And this is severe respiratory distress in an asthmatic that's in the middle of an RSI sequence that's just started for emergency intubation. You can just see all the intercostal retractions and the severe work of breathing that's occurring with that patient. Medical conditions that can help predict a difficult airway. So as you go through your medical history on your transport, you're going through your transport packet, different things can key up if you're thinking an airway problem might occur. Different types of joint diseases, we're looking for mobility problems that may happen, acromegaly. Thyroid or neck surgeries are a huge problem. If they've had scar tissue, adhesions, those create mobility problems in the neck and can create problems trying to get patients intubated. Tumors of the neck, genetic abnormalities. Epiglottitis is a huge one. The picture at the lower left is a great representation of severe epiglottitis on a pediatric patient. The inflammation and edema is so severe down in the airway, it is pushing the epiglottis up above the tongue. You're looking at the top horseshoe of that child's epiglottis sticking up into the oral airway or the posterior oral pharynx. So that you could imagine the amount of tissue disruption that's happening down in that airway and what you might visualize if you had to get in there. That's also a great representation of why with epiglottitis they tell us not to look into the airway, don't put tongue depressors down in the airway. If it's that swollen that all those structures are displaced, just the act of introducing something that may cause a gag reflex or a cough can completely occlude the airway and send the patient into respiratory distress. Previous intubation problems or problems in surgery, those patients can have issues during emergency intubation. Diabetic problems, chronic diabetics that mostly have circulatory problems can have problems during RSI. Advanced pregnancy, gross obesity, and pain issues. With the pain issues, we're looking more like medication administration, what's going to work, what may not work, and how fast those can be metabolized. Along the lines of predicting difficult airways, there's several mnemonics. There's all sorts of different things that are catchphrases that can help you remember. 3 of the most common that you'll encounter in flight and CCT operations for nurses would be like the moans, the lemons, and the DOA mnemonics. So let's move into some of those and things that we're looking for when we're going through those mnemonics during our patient assessment. So one thing you may encounter is a C-spine patient that's immobilized on a backboard, typically a trauma patient. That could lead into problems for airway management. Protruding tongue, somebody that has a short, thick neck, prominent upper incisors on their teeth can lead to problems inserting blades and clearance problems inserting the airway tubes or bougies. High arched hard palate, beard and facial hair. Dentures, actually dentures can present a problem if you don't remove them. Any type of airway management you're involved with, always take the dentures out. Don't ever try to do any kind of intubation with dentures in place. They should always come out. And then once they come out, no problem. Limited jaw opening, limited cervical mobility is a huge one. Any type of upper airway conditions like we've been discussing, any type of face, neck, or oral trauma, laryngeal trauma, airway edema, and again, that morbid obesity. For the lemons mnemonic, we want to look externally for any kind of disruption or any kind of anatomical differences. Evaluate 332. I'll have another slide for 332 to get into that a little more detail, along with the Mallampati score. The O stands for obstruction. We're looking for any kind of obstructions around the patient. I've got a great slide for that to demonstrate. Neck mobility, and then the scene or the situation that you're finding yourself in for the airway management. The moans mnemonic, with the M, we're looking for the mask seal. Are we able to get a good mask seal? Can we predict that the patient is going to be easy to ventilate with a good mask seal? Is the patient grossly obese, O, or is there any obstruction around the patient? Age greater than 55, again, no teeth, and then stiff neck. Looking at the 2 pictures I've got up, the one on the left, that guy's got a great Mallampati score. You can predict that you're most likely not going to have too many issues intubating this gentleman. The facial hair might create a problem. You just have to be a little more diligent with your mask seal. Whereas the individual to the right, the gentleman with the stiff neck, he is going to be a very big challenge trying to align the axis of the airway if there's no neck mobility at all. Let's look at that 332 a little more carefully in that lemon mnemonic. So when we evaluate the 332, we would take the patient's 3 fingers and put those up and see if they were able to put those 3 fingers into their mouth between their teeth. If they're able to open their mouth that wide, that can help predict that the patient may not have a difficult airway. Then we evaluate the 3 fingers below the chin, and then we roll that down into the 2 fingers right on the thyroid cartilage in relationship to where their chin is. So the 332. If the patient has normal 332, then the measurements in the upper airway should allow for challenge-free intubation. Let's look at the Mallampati score. So Mallampati score is when you have the patient open their mouth and you're looking at what you can see in that posterior oral pharynx and in the oral cavity. So class 1 is the patient's able to protrude their tongue. We can look into the oral cavity, the posterior oral pharynx. You might be able to see their tonsils, the uvula is visible, and that's associated with a grade 1 airway. And I'll get into that a little more with the Cormack-Lehane on the next slide, but a grade 1. Class 1 is a grade 1 Cormack-Lehane. Class 2, have the patient open, see part of the uvula, part of the posterior oral pharynx. The tongue is partially occluding the posterior oral pharynx, so we're starting to get some limited view of the anatomical structure. That is correlating to a grade 2 Cormack-Lehane on the airway. Class 3, starting to move into where there's very, very little visible in the posterior oral pharynx. And then class 4 is there's no posterior oral pharynx or uvula visible, and all you're seeing is tongue and hard palate. So that's a predictor of a grade 4 difficult airway. All right, we're looking at the Cormack and Lehane grading scale. Again, that's in relationship to that Mallampati score that we were just discussing. Predicting what the grade airway is that you're going to see when you get in there. So we're looking at the grade 1 Cormack and Lehane. All the anatomical structures are present. They're beautiful. You can see your arytenoid cartilages, the epiglottis, the glottic opening. It doesn't get any more perfect than that. It's beautiful, grade 1. Grade 2, we've got the epiglottis sticking there. You can see some of the glottic opening. It's probably going to be doable with a grade 2 airway with maybe a little bit of manipulation. Grade 3 is a problem area. All we can see is the epiglottis. We can't see any glottic opening. We can't see any structures. You would never want to try to do an intubation attempt with a grade 3 or grade 4 airway. Do not do any blind intubation attempts. We've got several tools that are available, several techniques that you can do. There's absolutely no reason to get into a grade 3 or grade 4 airway and try to muscle your way through or blindly stick tubes. We want to emphasize that any type of intubation attempt with our CCT program, you should be able to see that glottic opening and watch the tube go through that glottic opening. If you're not able to do that, abort your intubation attempt, go back to your oxygenation and ventilation phase. With thyroid manipulation, or we talk about the backward, upward, rightward pressure maneuver, one thing that's been shown in the studies is you can improve your grade airway by 1 to 1.5 just by manipulating the thyroid cartilage or the larynx. During your intubation attempt, you reach around and then you can manipulate that area, pull the cartilages up into your blade, and you can improve that visualization to get a better improved grade. You can take a grade 4 airway down to a lower grade 3 and really visualize the glottic opening. So manipulation on the external anatomy is paramount. One thing that's been showing up in a lot of the airway education that's somewhat new, it started back in 2019 with the JAMA study. This is the upper bite lip test, and you can have your patient bite their upper lip. How far can they move their upper teeth over their upper lip or the vermilion border, which is the separation between your lip and the skin. So if they can move those lower teeth over their incisors, over their upper lip, across that vermilion border, that's associated greater than 60% of the time. One study I read was greater than 80% of the time. It's associated with a non-difficult airway. If the patient's only able to get just to the lip part, they can't get across that vermilion border up to the top, you're going to run into some challenges with the airway and mobility. And then if they're not able to move or reach that upper lip at all, then you know that you have a predicted difficult airway. Again, that's the upper bite lip test. And I will bet if you're watching this slide, you are probably trying to bite your upper lip at this very moment. All right, let's move into the next mnemonic, which is DOA. That's one that's easy to remember, but we're looking at disruption, distortion, obstruction, or any kind of access problems that you may have with the patient. This is another situation where you may be asking yourself, okay, Crabtree, why are we learning this? There's no way I'm going to end up with a patient like this. And that's absolutely false. You can end up with a patient like this. A lot of these smaller medical centers that don't have the trauma resources can call for CCT, and you may end up with a patient. The one on the right with the airway facial disruption, you can end up transporting a patient where the physicians may not feel comfortable obtaining airway control, and they need to get the patient to a trauma center like UC Davis or Doctors Medical Center Memorial down in Modesto. You can absolutely end up in these situations. The one on the lower left, massive facial trauma with a impaling object to the face. They've done an emergency cricothyrotomy. We're looking at the endotracheal tube that's coming through the cricothyroid membrane. That could very easily be a CCT transport. And then what would you do if you had an accidental extubation from that ET tube, if that ET tube became dislodged and the airway closed during your transport to a trauma center? Situations can absolutely happen to you. So let's go back to just a moment when we're talking about distraction injuries and how those affect your clinical decision making. These are two very dramatic photos. The one on the right, probably a little more dramatic. As you can see, this gentleman's tripoding, he's having trouble breathing, he's leaning forward. There's probably a lot of blood that's coming out of this airway, and it's highly distracting and anxiety producing for the clinical provider. However, if you just kind of break it down and focus, get away from the distraction injuries, if you're thinking anatomically, this gentleman has blown the whole front part of his face off, which for us means the anatomy is probably very visible. On this type of patient, you can hyperextend their neck, and the epiglottis may just be sitting right there. You can pop a bougie or an endotracheal tube right into their airway. So again, distraction injuries, remember that term. I've seen a lot of nurses get into the trap. They get caught up in the anxiety. Then you have all the outside influences that begin to influence you, and then it affects your clinical decision making. Two very important things to remember with any kind of airway management scenario. This is going to determine the algorithm and the pathway that you're going to go down. You're going to run into two situations basically. Either you can't intubate and you can ventilate the situation or ventilate the patient, or you can't intubate and can't ventilate. So let's go back to the first one. We can't intubate and we can ventilate. So that's a situation where we've had an airway problem, you've tried to intubate, and you can't get the patient intubated for whatever reason that is. However, we default back to our BLS airway with a very good mask seal. We're able to ventilate the patient adequately, and we fall back to that. As long as you can ventilate and maintain oxygenation, you have time. So again, no distractions with the anxiety. You have time, we're able to ventilate. You can regroup and figure out how you're gonna manage that airway, whether it be a rescue airway or some other device, video laryngoscopy. You have time, you have options. When we have a situation where we can't intubate the patient for whatever reason again, and we can't ventilate, then that's a bona fide emergency. You do not have time. You have to instinctively react to save the patient's life. The patient will die if you are not able to ventilate and not able to intubate the patient. You have no time in those clinical situations. You would advance to your failed airway algorithm, immediately start looking for something that you're going to place through that cricothyroid membrane to establish an airway on that patient. Those are not the patients where you want to do repeated intubation attempts and thinking, I almost got it, I think I can get it, and then the patient will end up coding. So let's talk about some of that situational critical thinking that kind of goes through your brain as you're in these emergency situations. Again, a lot of this is predictive. As we make patient contact and we're communicating with them, we're doing our head-to-toe assessment, we're trying to see what's going on. You glimpse into their airway just to see if there's anything that may trigger an alarm bell in your brain for the transport environment. These are some great pictures of situations. The top left, again, we're looking at that Ludwig's angina. It's kind of funny because you'll get some inexperienced nurses that may not have worked ER and are not real familiar with Ludwig's angina, and they'll say, hey, what was your last transport? And you're like, oh, it was Ludwig's angina, and the patient had a lot of swelling. And they're like, oh, did you give nitro for the chest pain? And I'm like, well, no, Ludwig's angina is the soft palate down into the floor, the mouth with the inflammation down into the throat. So it has nothing to do with cardiac stuff. But this patient in the top left, the Ludwig's angina is advanced so far that all the soft tissues are protruding up. It's forcing his tongue up to the hard palate, and you could see that there's a real clearance problem in that airway if you had to intubate that patient. We can also imagine if there's that much going on, how that might extend down into his neck. The lower left is a pediatric patient, again, with the same type of situation, that tongue protrusion with the lower floor infection extending down into his neck. You can see it's on more the left than the right. Paratonsillar abscess, really encountered a lot of that in our ER. Our ENT doc would come in and lance those, although a lot of these were so advanced, like the one in the center, that the patients would need to be RSI and intubated. It's highly likely that you can get one of the smaller medical centers that's not capable of dealing with this type of situation, and they would require CCT transport. And again, going back to minimum safe skills, those ER docs are expecting that that CCT nurse on board that ambulance has the capability to manage that airway and intubate or rescue that patient if they went into distress. The one on the right is very pronounced, again, Ludwig's angina with a severe infection extending off to the side. And again, the one at the bottom, again, this is one of those distraction injury situations. It looks absolutely horrible. It's a gunshot wound to the face. There's tissue disruption everywhere. And looking at this situation, that would immediately be a can't ventilate, can't intubate situation. We can't make out any of the anatomy in the oral pharynx. A bag valve mask is obviously not going to work or get a seal on this. So this is a patient where you would immediately go to a failed airway algorithm, get something through the cricothyroid membrane. And that's what we're looking at there. And it doesn't even look like they wasted time putting the antiseptic down and scrubbing. It looks like they just cut and shoved the ET tube right into that cricothyroid membrane to get the patient oxygenated. I did see that the nurses were able to get a oral gastric tube in because his tongue is a little bit visible there. Again, with facial trauma or any kind of head injury, no nasal tubes going up, no NG tubes or nasopharyngeal airways. With this one, I guess it's okay with that one. You can see the oral pharynx there. Assessment and reassessment is of paramount importance for the CCT nurse in the back. If your patient is going to deteriorate or have a problem, you want to be ahead of the curve. You want to be predictive of those situations happening so you can have your equipment, your supplies, your medication, everything ready to go. One of the biggest failures that I have been involved with on the helicopter or ground CCT, especially training new nurses, is they're not able to recognize a failure or a potential failure when it has occurred. And they're not changing rapidly enough. They're getting distracted with the outside influences. They become stressed out with what they're seeing or what they're encountering, and they're not reacting quick enough or recognizing that there's a problem. Of course, I had to put some pictures of my family to lighten up our conversation today a little bit. To really drive this point home, because that's really important to me, never repeat the same actions over and over. Those clinical distractions can really be the downfall as a CCT nurse in the back of an ambulance or even working in the emergency room. Always do something different. Never repeat the same actions over and over again, expecting the same results. The perfect analogy is that fly that's on the glass that's trying to get through the window. I got to get outside, I got to get outside, and keeps hitting the glass. I cannot tell you how many intubations I've been in my career where the provider's trying to intubate and they're caught in a situation where they're like, I can almost see it. And they're just moving the blade back and forth. They're trying to muscle the endotracheal tube in. The meantime, the oxygen's going down. And in those situations, somebody needs to speak up, stop your intubation attempt, discuss what's happening, do something different, add a bougie, ramp the patient, tilt the head back, get a video laryngoscope, get a glide scope, adjust medications, do something different. Never, ever, ever repeat the same thing over and over again. Don't get into that trap. All right, let's get into the actual practice and the different steps that are happening. Just as a quick review, the 7 Ps that we're really trying to drive home into your thought process: the preparation phase, pre-oxygenation, pre-medication, paralysis with induction, placement of the endotracheal tube, proof of that placement, which is vital, and then the post-intubation management of that patient. So as we all learn in ALS, with setting up intubation, we want to have our ambu bags, oxygen resources available, and the suction. Make sure with any ambulance you're getting in that you are checking your suction, you're checking your oxygen. Make sure that the front crews have the inverters and the main switches on so that everything operates in the back of the ambulance. Whenever I get into the jump seat, I'll flip up all the switches just to make sure that everything is absolutely functional. The one time you don't do that will be the time that you need suction, or you'll find out that the main hose coming down to the ambulance is not hooked up to the canister, or it's missing, or you don't have the supplies that you need. Always check the vehicle that you're in. The RN is ultimately responsible for what's happening with that patient care, what's happening in the back. Make sure that all of your intubation supplies are there. You should have done your pre-start of shift check. You want to have multiple handles, a variety of blades, our ET tubes, a variety of assortment available to you. You want to make sure you have at least one IV line. For CCT best practice, whenever you're doing a transport with any kind of airway or potential airway problem, start a bag of normal saline that's just TKO. There's nobody in the world that's going to care about that. And just have a normal saline bag just sitting there ready to go, hooked up to the patient. You can always take it off and throw it away when you get to your receiving facility. At least it's there. If you have an emergency, it's one less thing you have to deal with. In your RSI pack, you'll have all the agents that you need to implement an RSI, all your backup plan equipment, pulse oximetry, capnography, colorimetric detectors, ET tube holder, and think about how you're going to position the patient with what blanket rolls or bags or whatever you're going to use. Again, the patient should already be on the cardiac monitor because we'll be monitoring for the dysrhythmias. We'll be looking for bradycardia, tachycardia, any kind of ectopy that starts to occur. Blood pressure monitoring should be started during an intubation attempt every 3 to 5 minutes at minimum. Again, plan for anything. Do you have a manual blood pressure cuff just in case your monitor fails? We're monitoring for high and low blood pressures during intubations. Again, continuous pulse oximetry and capnography. Positioning the airway is of great importance. Many airway failures that I've been involved with, especially with newer providers, they're not really tuned in to positioning the airway. They're more focused on the mechanics of getting the blade in, getting that tube in, and that's what everybody worries about. To set yourself up for success, the greatest likelihood of success is positioning your airway axis so that you have a great visualization of the airway. The slide you're looking at with the 2 pictures there, the CT, it can show you how when that head is not tilted up into the sniffing position or hyperextended, the airway is curved, and it's very hard to obtain visualization of the laryngeal axis to get to the airway. Just moving them up into the sniffing position or elevating that head a little bit really lightens up that alignment and adjusts your axis. To the right, great textbook example of the oral axis, the pharyngeal axis, and that laryngeal axis, and how those can change just by altering the patient into that sniffing position or raising their head. That's our goal for intubation. Great picture of my daughter. So this is a 9-year-old, and you can see the upper picture. We're looking at the tragus of the ear to the suprasternal notch. That's our laryngeal alignment. We're going to adjust those pharyngeal axis just by elevating the head or ramping the patient. One practice that a lot of airway providers are doing now is raising the head of the gurney 20 to 30 degrees for all patients. It helps with gastric insufflation to help prevent that. It also helps to, because you're not forcing open that esophageal sphincter when the patients are laying supine, resulting in emesis coming into the airway or regurgitation. Raise the head of the bed 20 to 30 degrees. We can ramp the patient. On Isabella, we put a blanket roll under her shoulders and put an additional one up by her head, and we can see how that adjusted the airway axis. That suprasternal notch and the tragus of the ear are in complete alignment. So we know if we get in there with a blade, we should have great visualization of that airway. You can imagine if we got in there with a blade on that first picture, the airway axis is not in alignment, and that airway is going to be very challenging to get the patient intubated, even on a normal, healthy person. One contraindication to raising the head or hyperextending the neck or doing the ramping techniques are going to be trauma patients. If you have a confirmed cervical spine injury or the patient's fully immobilized on a bed, those are the kind of patients where we want to put into reverse Trendelenburg, again, helping to prevent the possibility that they can vomit during the process, help protect the airway, so reverse Trendelenburg for them. Regarding C-collars, you never want to try to start an intubation with a C-collar in place. The only exception to that rule is if you have video laryngoscopy or Vivitrac or some other video laryngoscopic device, then it's possible to intubate with a C-collar, although still not recommended. The only other time you'd want to try to keep a C-collar in place is if you have a confirmed high-grade cervical fracture of some type. Otherwise, the C-collar should always come off. It's going to interfere with the mobility of the mandible and your ability to ventilate and get the patient intubated. Always make sure you have an assistant that's maintaining inline stabilization of that cervical spine on either side of the head so that there's no movement or very minimal movement as you're moving the airway structures. Here's some great examples of ramping a patient. Again, difficult airway assessment. We're looking at gross obesity here. Look at the airway structures around the neck and what that may look like for a traditional intubation attempt. It would be impossible. This is anxiety producing just looking at this slide. So the top left, they've got the head of the bed up, that 30 degrees. They got several blankets under the shoulders, moving up with additional blankets behind the head to obtain optimal airway positioning and align those axes. The one on the right, again, this is before they were emphasizing kind of raising the head. So this woman is laying supine, and they've got probably 10 or 12 blankets underneath for ramping and getting that head up to align that axis. And you can see on that slide to the right again, look at the tragus of the ear going to that suprasternal notch and draw a line between there. You can see how successful they were in getting that axis alignment correct. We move into the pre-oxygenation phase. There's a lot of wonderful material available on different airway sites and education. I personally like the EM Crit with Dr. Scott Weingard. He's a great guy to learn from, especially for airway management. Pre-oxygenation, there's a lot of studies, a lot of information about this phase. It's such a critical phase for intubation. We pre-oxygenate a patient beginning with 100% non-rebreather mask if you can. We can also use a bag valve mask where you attach the oxygen going to the wall, turn that up to 15 or 25 liters, as high as the regulator will let you go. And we can also add a nasal cannula, just a standard nasal cannula, not a high flow nasal cannula, just a standard run-of-the-mill nasal cannula in your patient. Turn that up to 15 liters, get that on your patient, and then cover that with the BVM with your high flow oxygen. And that's how we do pre-oxygenation. What we're doing is we are creating a pressure gradient in the airways, and we're creating a level of CPAP. And what that's been shown to do is increase nitrogen washout, really saturate your patient with oxygen, and it buys you time. It's going to take the patient longer to deoxygenate during your intubation attempt if you follow these processes. In a normal healthy person that's experienced a medical emergency that requires intubation, the studies have shown that you can get as much as 3 to 4 minutes of apnea if you follow this high flow pre-oxygenation sequence. This is referred to in all the literature as passive oxygenation. So we are passively oxygenating with a pressure gradient. One thing that we want to do when we have a BVM over a patient and we're getting a very good seal on the patient, we're letting that oxygen come through the bag, the patient's inhaling that, they have the cannula that's blowing at 15 liters. Do not provide any kind of positive pressure ventilation by squeezing the bag. If you have your EMT assistant on the ambulance helping you, make sure you're providing a good crew brief and you're explaining to them, we're holding the mask on the airway, we are not squeezing the bag. The inclination is going to be for somebody to start squeezing that bag, and then that can result in emesis into the airway. Can also cause, it can be very anxiety producing with the patient. If your patient does need ventilatory support during the pre-oxygenation phase, then this is going to turn into a two-person operation. You have one person maintaining and just focusing on that tight mask seal, and then you have the other person ventilating to help support the patient. One thing to consider if the patient has a real high likelihood of aspirating or regurgitating during the process, you can think about placing an NG tube if they're semi-conscious in the pre-oxygenation phase. Again, we're kind of emphasizing raising that head of the bed 20 to 30 degrees and reverse Trendelenburg for the trauma or C-spine. One thing that you'll also want to do that can help add pressure to the airway to improve oxygenation is a PEEP valve on the bag valve mask. We add a PEEP valve to that. It's going to increase the level of PEEP in the lower airways, help pop open the alveoli. Again, the person that's holding the mask, that's a critical position. They really need to understand their job. Any break a seal with the mask is going to cause your PEEP to go away. One question you may ask yourself is, does the nasal cannula interfere with the mask seal? And all of the experts show that with the two-handed technique with a standard nasal cannula, it does not interfere with the mask seal. You can get a really great seal and pre-oxygenate your patient really well. That's not the case with a high-flow cannula. So if you have one of the green, rigid, round diameter cannulas, you will have mask seal problems. We're only talking about a standard run-of-the-mill cannula that you'd find in the back of your ambulance. Those are the ones you want to use. For mask seals on pediatric patients, I've got pretty big hands. We're stabilizing the BVM over the patient to pre-oxygenate and using the C technique over the mask. Sometimes it's a little hard to get both hands down, so that's how we would stabilize that in a pediatric patient. Could we use BiPAP or CPAP in a patient like this? The absolute answer is yes, we could. Anything that you can think of or critically go through and think, how can I pre-oxygenate this patient? How could I increase a level of PEEP that can help do nitrogen washout? If you have BiPAP or CPAP readily available, absolutely. You could put the patient on a mask, crank them up to 100% FiO2, let them breathe, let them get the pressures for a pre-oxygenation phase. Absolutely wonderful idea. Another thing that you could even add to that would be a little bit of pre-medication like fentanyl. Give the patient maybe a half dose or a little bump of fentanyl so that it helps relax them. They can take nice slow breaths while you have your BiPAP and your CPAP in place. So that was step 2, pre-oxygenation. Now we're moving into step 3, pre-medication. For our pre-medication phase in step 3, these are medications that we're going to give 2 minutes before the RSI sequence. What we're doing with these are blunting the body's response to the intubation attempt. The body responds by either bradycardia, tachycardia, hypertension, hypotension, hypoxia if you haven't pre-oxygenated them very well, or they have little reserve. We also increase intracranial pressure when we intubate and intraocular pressure. If you haven't medicated adequately, they can still have a cough and gag reflex. So with our medications, we're trying to blunt these reflexes and help prevent any kind of negative outcome. The first pre-medication would be lidocaine, generally 1 to 1.5 milligrams per kilogram. Again, 2 minutes before intubation. This is really reserved for patients that we are looking at rises of ICP in. This is a patient that has like a traumatic brain injury that we're about to intubate. Somebody that's had a very large stroke, hemorrhagic or ischemic, and we're really worried about ICP. Lidocaine administration can help blunt that and prevent that. Atropine, it used to be in the early days, we would give atropine to every pediatric patient whenever we did an intubation attempt. Now what we're doing is atropine is only given to patients that are bradycardic. So before your attempt, if your patient, pediatric or adult, is bradycardic, then we would go ahead and pre-medicate with atropine. The cause of the bradycardia during the intubation attempt is vagal stimulation as we move the blade into the vallecula or down into the lower airways. So that's what we're trying to blunt when we give the atropine. Kind of talked about fentanyl already. Fentanyl is great for reducing anxiety. It can also help reduce the pain that they might be having. It helps reduce rise in ICP, although minimal. It does help reduce rise in ICP. Again, 2 minutes before. It's usually a smaller dose, 0.25 or up to 1 microgram per kilogram. Now we move into step 4, critical step. Make sure that all your team members are aware of what's about to happen. After you push your paralytic or your induction agent, then you got to focus on exactly what's going to happen as your patient becomes apneic. So for induction agents, the first one we'll talk about is etomidate. We used to give etomidate to everyone. There's quite a few airway studies that are going on right now as of this moment because of the adrenocortical insufficiency that happens after a single dose of etomidate. There's several studies that have shown after a single RSI attempt with etomidate administration, later on the patient may have a hypotensive episode from this adrenocortical suppression, and those result in longer hospital stays, greater ICU admissions, and greater mortality. So there hasn't been a direct link correlated to etomidate administration. However, a lot of the studies are showing that this does occur in patients that have received etomidate. A lot of anesthesiologists, and I'm sure Dr. Wolf can talk to this a little bit more, being in anesthesia, many anesthesiologists have moved away from etomidate in favor of ketamine or propofol as an induction agent because of this. For etomidate, the normal dose for RSI is 0.3 milligrams per kilogram. It usually starts to work in about 30 seconds. It does cause some respiratory depression, and it lasts again for about 5 minutes. Your induction agent is always given before a paralytic. The next induction agent would be ketamine. Ketamine's a dissociative agent, and it's very kind of a complex medication. It does different things at different dosing levels. So one thing I'll just quickly mention since we're on ketamine, there is a pain dose that works very well, and a pain dose is 0.2 to like 0.8 milligrams per kilogram, and that's given slow IV push. We're not creating a dissociation with that, but it does alter the reality and the pain perception. It works really well for pain and anxiety. For our purposes here as an induction agent, we want to dissociate the patient from reality. And the dissociative dose for RSI is 1 to 2 milligrams per kilogram. Generally, the studies are showing 1 milligram per kilogram can achieve dissociation in a normal patient. Typically, you'll have a patient that's very anxious, they're struggling, they're in respiratory distress, you're working with them. After you give ketamine, suddenly all the movement stops, their eyes stay open, they're kind of tracking back and forth, and they're not really able to respond. And those are your cues that your patient has been successfully dissociated. The onset's usually 30 to 60 seconds. It does happen very quickly after IV push, and it's pretty short acting. Again, induction agents are always given before the paralytic. Do not administer the paralytic first. Succinylcholine is our paralytic. So after our induction, we'll say with ketamine, we give those rapid IV push. Our paralytic and our induction agents are rapid pushes. These are not where you're sitting here timing, where you're giving the administration over 2 to 3 minutes, like I've seen some nurses try to do. These are IV pushes like you would give in a code situation. For our paralytic succinylcholine, this is a depolarizing agent. The dose is 1.5 milligrams per kilogram. Because it's a depolarizing agent, it depolarizes all the motor end plates at the acetylcholine receptors, and the patient becomes flaccid all at once. It's rapid acting, usually within 30 to 60 seconds, and the overall duration of succinylcholine, it says like 3 to 5 minutes, but in actuality, it's about 5 to 12 minutes. There are several contraindications to succinylcholine and a couple that really you need to pay attention to. The first one is severe burns. This only holds true for severe burns that are greater than 24 hours old. The acetylcholine receptors on old burns seem to proliferate up the muscle tissue. So there's more acetylcholine receptors that are present. So when you administer succinylcholine, you get a depolarization for more receptor sites, and that can be very dangerous with the hyperkalemia and electrolyte abnormalities. Again, it's 24 hours old. If you are encountering a patient that has massive facial burns or burns all over their body, succinylcholine is perfectly safe to administer in those type of patients. We're only talking about burns that are greater than 24 hours old. Massive crush injuries that are greater than 8 hours old, again for the same concern, more available acetylcholine receptors that can depolarize and cause problems. Spinal cord injuries, the same thing, greater than 3 days old. Because it increases intraocular pressure, any kind of penetrating eye trauma or glaucoma would be contraindication for succinylcholine. If there's any kind of remote history of malignant hyperthermia, succinylcholine can induce malignant hyperthermia in those patients. So any type of remote history, even if it's just a family history, you would not want to give succinylcholine. And again, any kind of neuromuscular disease, multiple sclerosis, or any kind of paralytic, anything like that, paralysis, succinylcholine would be contraindicated. The big one with succinylcholine, especially in the hospital atmosphere where patients may be receiving potassium supplementation, we may be transporting those patients and you may be faced with a respiratory emergency and you have to choose what paralytic you're going to give. You should always know what the potassium level is. You can expect a 1 to 1.5 bump in the patient's potassium after you give succinylcholine with those receptors all depolarizing. Potassium is going to move from intracellular space to extracellular space and drive up your potassium level. If you have a patient with potassium of 5 or 5.5 and you give succinylcholine, that's going to jump to 6 to 6.5 or even higher. There are two just horrible intubation situations that I've been involved in my career that are burned into my memory. Both of them are hyperkalemic episodes where the level was not paid attention to, succinylcholine was administered, and the patient had a very bad outcome. Make sure you are absolutely paying attention to this. I would recommend not administering any type of succinylcholine if the patient's potassium level is anywhere near 5 or above. A lot of pre-hospital providers with flight programs have moved to rocuronium for that particular reason with succinylcholine because of the dangers that are associated with it. Rocuronium is a non-depolarizing agent. It does take a little while longer to work, and rocuronium just moves into the receptor sites so that acetylcholine cannot bind onto those motor end plates. So it blocks the receptors, and it takes a little bit longer for it to move its way through and block all those receptors. So it's not a depolarizing agent. The dose is 0.6 to 1.2 milligram per kilogram. We would administer that, again, immediately after our induction agent. Again, rocuronium takes longer to work, about 60 to 90 seconds in my experience. What I will normally do is give rocuronium, and then I try to think of some little joke to tell everybody around me to help reduce anxiety as we're waiting for the rocuronium to work. My favorite one is my daughter's, "Why does a cow have no legs?" Or "What do you call a cow with no legs?" And the answer is ground beef. And then everybody looks at me like, that's the most ridiculous joke I've ever heard. But in the meantime, that's bought me about 60 seconds so that we can then move on and the rocuronium's had time to work. After we've administered our induction agent, our paralytic agent, they've had time to work. The patient is now completely flaccid. One way that we can check for the flaccidity is I will normally grab their mandible and I'll just kind of jiggle that a little bit. And once their mandible is flopping around, we know that we have complete flaccidity with the patient. Our patient's already positioned. I've got my airway axes aligned, and then I'll go ahead and move into the intubation attempt. Again, it's vital that you wait for the patient to be fully flaccid. A lot of times, again, with distractions, the anxiety, with things that are happening around you, it's very easy to give rocuronium and then 15 seconds later you're inserting the blade because you think maybe 60 seconds has gone by and the patient's not fully flaccid, and now they're trying to bite down on your blade, but your blade's already in there and you're trying to muscle through your intubation attempt, and that's not a situation you want to be in. Take the moment, take the time, make sure your patient's fully flaccid after your medication, then go for your intubation attempt. If you get into the airway and your intubation is going to fail, you've reached around, you've done manipulation of your thyroid cartilage, of your larynx, you've done the backward, upward, rightward pressure maneuver, and you just can't get visualization of the airway, then immediately stop and go back to your default BLS, BVM ventilations with a tight mask seal and reoxygenate your patient. Do not linger in the airway attempting to manipulate. If you can't get it within the first 10 seconds or you don't have great visualization, pull back out, regroup, and think of what you're going to do different. Again, always change something. Do not go immediately back into the airway with the same blade, the same positioning, and the same technique expecting the same result. That's where people get into a big trap. After the patient is reoxygenated and you've bagged them back up, everything's looking good, you've changed something, then we can move into attempting the intubation again with a different adjunct. Once the blade is going into the airway, we focused on the anatomy and the anatomical structures, and that's what I really wanted to drive home at the beginning of the presentation, and this is where this comes into play. There's two schools of thought when inserting the blade. The first one, which is the one that I like to preference, we insert the blade slowly and methodically, and you're identifying the anatomy as you're going down. So the blade's moving across the tongue, you're moving down into the oral pharynx, the posterior oral pharynx, and then you're beginning to look for the back airway structures, that epiglottis, you start looking for the cartilages around the glottic opening. So visualizing the anatomy. It's also very helpful if you're communicating to those around you what you're seeing. So I'll communicate to my EMT partners, or if I'm with a medic, this is what I'm seeing, this is what I'm doing, I can see this now, this is what we're seeing in the airway. At this point, as you start to get into the anatomy section of the airway, you want to use your backward, upward, rightward pressure maneuver to maximize your visualization of the anatomy. It's also at this point that you never want to break visualization of your airway. Frequently, a provider will get into the airway and then they'll say, oh, I think I need suction, or I'm not sure what I'm looking at, and they'll distract and look away. And as they look away, they move their hand, the epiglottis will drop down from the blade, they look back in the airway, and now they've lost all their anatomical structures. Do not break visualization of the airway. The next tip that we offer is you can have an assistant pull onto the right side of the mouth, and that really increases the visualization that you have around the oral pharynx and for accessing endotracheal tube. Another tip is with your laryngoscope blade, just tilt it slightly to the left after you have really good tongue control, and that will also increase visualization down into the airway. So let's talk more about complications that can occur with intubation. So again, if you miss or you're unable to intubate, all the textbooks say you get a full 30 seconds. We're emphasizing within 10 to 15 seconds, basically 10 seconds. You're going to know. Once you get in, if you reach around, you're not able to get great visualization within that 10-second period, pull back out, regroup, reposition, discuss what you're going to change, ramp the patient, increase the head angle, align axes, grab a different blade, whatever it was that you think contributed to your missed attempt. Have your difficult airway adjunct standing by. Let's review the failed airway algorithm, because that's the point we're at now. Let's say that you've done your first intubation attempt. Within that 10 seconds, you're not able to get the patient intubated. We've regrouped, we've repositioned, we've tried different things, and now we're going to go in for our second attempt. We get 2 attempts with ProTransport. We go in for our second attempt, we're still not able to visualize all the anatomical structures, we're not able to successfully get the patient intubated, and then we back out and we can ventilate the patient. So that's just going to be difficult airway algorithm where we would insert a rescue airway, maybe we can get an eye-gel in place since we're able to ventilate the patient, and then we've got the airway secured and we're good to go. Although definitive airway standard for securing an airway is something in the trachea, the eye gel as a rescue device is going to get you as a bridge. If for some reason during this process, after the paralytics and after everything has happened, you move into a situation where now we have a failed airway where you can't get the patient intubated, and now we're having problems ventilating. The oxygen levels are falling. We're not getting the chest rise that we normally had. And now we're in a real progressing situation. We moved into our failed airway algorithm. Again, the extraglottic device can be inserted at the very beginning of the algorithm, and if they're oxygenating with that, then fine. If they're not oxygenating with an epiglottic device, then we move into something that needs to go into the cricothyroid membrane. For the failed airway algorithm, again, these situations are we can't intubate, we can't ventilate. In those situations where you can even think the patient may be a difficult airway during your assessment, there's nothing wrong with finding the cricothyroid membrane before you do anything and just marking on the patient's neck. Okay, if this really turns into a big problem and I'm not able to get this patient intubated, then where's the cricothyroid membrane? So I'll take a little Sharpie pen and just make a little mark. This is where I'm going to go if I'm not able to get this patient intubated and I get into a failed airway situation. So to meet those, we're not able to intubate, we're not able to ventilate, you're not able to ventilate through a rescue device, you're not able to maintain an SpO2 greater than 90%. And those are the times where we want to move into something that's going to go into that cricothyroid membrane. That could be a surgical airway, commercial cricothyrotomy device like the Quick Trach 2, or a needle cricothyrotomy with the jet insufflator, which is a standard for a lot of EMS agencies in our area here in Northern California. And we're going to cover all of those in our skills section. We're moving into step 6. So we have our patient successfully intubated. We watch the endotracheal tube go into the trachea through that glottic opening. So direct visualization is an objective method. If we're in the hospital, obviously we grab a chest x-ray. If you're assisting maybe in the ER before you transport, you've assisted with an intubation, then you'd want to get a chest x-ray before you depart just to make sure that that ET tube is in a great position before transport. Continuous pulse oximetry, we're monitoring that. The gold standard is waveform capnography. You can use a CO2 detector and then the colorimetric device. We have those available, but again, the gold standard is the waveform capnography. Subjective signs, absent epigastric sounds, equal breath sounds with equal rise and fall of the patient, and then securing the endotracheal tube. There's several commercial holders that are available. The one at the top right is currently what are on a lot of the ALS ambulances. If you find yourself in those, in our intubation equipment, we'll be looking at the AMBU one that's in the middle. This endotracheal tube device has access on either side for suction catheters, and you can visualize what's happening into the airway. This holder is designed to pinch the tube a little bit, so don't get distressed if you see the ET tube deform a little bit. It's designed that way. That's normal. For pediatrics, specifically infants, we're looking at a neobar. The neobar adheres to either side of the infant's cheek, and then the endotracheal tube is taped on the center section. The only thing that's important with this I'd like to mention is you need to hold your hands on either side of the infant for the adhesion for at least 30 seconds for adhesion to take place on the skin. Otherwise, that holder can fall off the skin. Standardized checks are done in the transport world, whether CCT or air, with every patient move or transition. So what that would look like in your charting when we're doing chart reviews would be something like endotracheal tube placement confirmed, after placement, standardized checks including equal chest rise and fall, the breath sounds are equal bilaterally, absent epigastric sounds, appropriate end-tidal CO2 waveform visualized. I've even had some medical directors that want us to document that it was a rectilinear waveform. So once you spell out one time what those standardized checks are, then any subsequent patient moves, just document something like standardized checks were performed, and everybody already knows what those standardized checks are. Those include any type of onloading or offloading from the ambulance, any kind of patient movements on the gurney, sheet transfers back and forth to hospital beds, any movement with the patient where there could be a possible dislodgement. And again, the transport standard of having 2 strips printed out before and at the end of the transport with that end-tidal CO2 waveform visible. If you were trained early in ALS, you probably may have used an esophageal detection device for endotracheal tube placement. You've used the colorimetric devices. There's a few other things that came out with products to check for endotracheal tube placement. All of that stuff put to the side, that's wonderful. The gold standard is end-tidal CO2 capnography. The endotracheal tube is not in place unless you see an end-tidal CO2 waveform. That's how you know your tube is in the trachea. You're constantly reassessing your patient during the transport. If at any time you lose your end-tidal CO2 waveform, stop everything. Troubleshoot the monitor, work back to the patient, figure out what has happened. Has the tube become dislodged? Do not allow a patient that's intubated or has a trach in place that's on a vent to go without an end-tidal CO2 waveform. That's just not, you have to know that your airway's in place. For post-intubation management, we'd want to place an NG tube or an OG tube placement. Again, NG tube contraindicated for any kind of facial trauma or anything going on trauma-wise on the face. Again, that's for gastric decompression. We want to medicate our patients post-intubation, extremely important. So we want to look at sedating and possibly paralyzing our patient. So old school level of thinking, immediately after RSI or intubation, we would give a quick dose of sedation and that would immediately be chased by a paralytic. So now what we want to do is we'll give certain levels of sedation, hold off on a paralytic unless it's absolutely necessary or you could clinically justify why you need to paralyze your patient post-intubation. For sedating measures or agents, we're looking at Versed and fentanyl. For the paralytics, we want to move to a non-depolarizing agent. Again, depolarizing, short-acting, only for emergency intubations. So our longer-acting, non-depolarizing are vecuronium and rocuronium. For post-intubation management, it's the expectation that after you've got a tube in place or you've got a cricothyroid device in place, if you're not using the jet insufflator, you're going to put the patient on the ventilator. Standard default settings would be a mode of assist control. On all emergency intubations, you want to start off with 100% FiO2, usually defaults to a start-off rate of like 12 or 14, and your guidance for ventilator starting is 6 to 8 mLs per kilogram for tidal volume, and that's going to be ideal body weight, not the actual weight of the patient at the time of the transport, just ideal body weight. And then all patients should get a level of PEEP beginning at 5. Do I need to administer more sedation or paralytic? So this is part of the ongoing assessment that as a CCT nurse you're doing in the back, and you're trying to assess what's happening. Many times nurses will pick up transfer patients that are already on sedation. They'll begin the transport and the patient in the back of the ambulance as they're hitting the rough roads, the ambulance is swaying back and forth. The patient's somewhat sedated, but they're still experiencing all these outside influences. Their heart rate's going up, they start becoming tachypnic, and then the nurse is like, well, they've been fine on this sedation for the last couple of days. How come I'm having problems now? So those are patients where you'd want to increase your sedation level. Signs that you're having to need more sedation include more patient movement, increasing heart rate, increasing blood pressure. If the SpO2 begins to fall because they're hyperventilating, they're becoming asynchronous on the ventilator, you start having changes in muscle tone, they're having facial muscle tension. These are all indicators that the patient's going to need more sedation or possibly a paralytic. So then you think, okay, at what point do we administer a paralytic? Basically, if it's gone on to the point where the patient is asynchronous on the ventilator, they are starting to desaturate, you've already given some level of sedation and it really hasn't had effect, then those are the patients where we want to administer a paralytic and then take complete control of the patient's respiratory efforts and their oxygenation, and we can control those a lot better. This happened a lot with a lot of the COVID patients that I was transferring between facilities. And after we administered the paralytic, you'd see the O2 sats come right back up. Again, it's the responsibility of the CCT nurse to make ventilator changes. You have to feel comfortable giving sedation and making changes on the ventilator. If that's something you haven't worked in critical care before, you're not that familiar with ventilators, and you may be hesitant to make changes in PEEP or changes in tidal volume or increasing the rate. And those are things that we're going to go with in our education program. But it is the nurse's responsibility to have knowledge and know what to do in those situations. Know when your patient's under sedated, when you should increase the propofol. Let's talk about restraints for a minute. When I worked in the emergency room or ICU, every single patient that was intubated had bilateral wrist restraints on right down to the bed frame. The patients absolutely could not move at all. Once I moved into the transport world, I always made it a point that none of my patients would be restrained. You have the CCT nurse right with the patient. You're watching everything that you're continually reassessing. And if you're not doing that and you have to restrain your patients, then maybe you need to look at how you're evaluating your patients, how you're constantly reassessing. I have found that restraints in a CCT transport environment, especially in the ground ambulances, they're moving back and forth, the bumps in the road, and then you add the fact that they can't move their arms at all and they're tied down, can add to oxygenation problems if they become tachypnic and anxious, and it adds a layer of things that may not be necessary. So unless you absolutely have to have restraints, my recommendation is just don't use the restraints, or we tie them in the front to help keep their hands from falling down to the sides of the gurney. One thing that we'll mention for pro-transport patients that are intubated, our company standard will be to have a C-collar in place. Even though this is not a trauma patient and you may be questioned at the receiving facility, why is there a C-collar in place? It's our company standard. It helps maintain that inline stabilization, and it can help minimize endotracheal tube dislodgement. So for pro-transport, our standard will be any intubated patient with the ET tube coming out needs to have a C-collar in place. It's just an extra margin of safety, and the receiving facility can just take that off. So we've wrapped up our 7 P's of intubation, all those different steps, kind of explained in detail most of those steps. Now we're going to move into additional details, drill into some finer details and techniques of intubation, different complications that we can run into, and special topics for the transport environment. And look, we can even teach a 5-year-old how to operate a Zoll CCT monitor. Clinical application points that let's discuss a little bit. One thing that you should never do, especially with the distractions that we talk about, or distracting injuries or outside influences, is intubate in a moving ambulance. The last thing you want to do is be the CCT nurse in an ambulance that's code 3, trying to get to the higher level of care as you have a patient that you're trying to do the 7 Ps on. You can go ahead and pre-oxygenate, do all the steps up to the point of when you're getting ready to intubate. At that point, you want to pull the ambulance over. The ambulance should not be moving. Take your time. There's no distractions. Methodically get your patient intubated and then restart your transport. Don't want to intubate in a moving ambulance unless you have a Vivitrac device or other type of video laryngoscopy where there's not that much manipulation that occurs in the airway. Those devices you absolutely can use in a moving ambulance. The Vivitrac can also be used in a cardiac arrest patient where you don't have to stop compressions. That movement doesn't really affect what you're visualizing in the airway with the high angle of the blade. Another tip, especially for CCT of intubated patients, a common scenario you may, or maybe not so common, you may encounter is a tube that may become partially dislodged. You have an end-tidal CO2 waveform that keeps dropping off. You can't quite figure out what's happening. On the ventilator, you show a low PEEP alarm, you show a low volume alarm, you show a disconnect alarm. Then all the alarms go away, the pressures look fine, then the end-tidal CO2 waveform drops off again, and you can't figure out what is happening with the patient. The very first thing you'd want to do is grab your Vivitrac or even direct laryngoscopy, go in, visualize, and see where that endotracheal tube is sitting. I've had several instances where the tube has become dislodged just a little bit or just enough that it's not seated fully past the glottic opening and it's creating an air leak. Another situation that may happen similar to that is a retention balloon that has become ruptured, or it may have a small cut on it, and it doesn't really become recognized until you're in that ambulance and you're started your transport, and then you start getting all the vent alarms that keep coming up: low pressure, disconnect, low pressures, and I don't understand what's happening. And you're looking at the pilot balloon and the pilot balloon is flat. Those are great situations that you can use a flex guide or bougie to do an endotracheal tube change out, and we're gonna go over those skills. Those are perfectly easy to do in the back of an ambulance quickly and safely. Again, another talk with C-collars. You should not perform any type of intubation attempt with a C-collar in place. It needs to be removed with inline stabilization maintained. Again, that does not apply if you do have a high-grade cervical spine fracture that's confirmed, or if there's any other reason why you can't really move the head. So otherwise, remove the C-collar, inline stabilization, and then get your patient intubated. If you have patients with halos or helmets, you kind of have to figure out how you're going to operate around those. For helmets, you'd not want to transport a patient where they have like a football helmet in place or a motorcycle helmet in place. A lot of times with smaller emergency rooms, they may be reluctant to move those in trauma patients. The absolute standard of care, and any TNCC trauma course or ATLS trauma course you'll go through, the standard is to remove the helmet, put the patient in full C-spine precautions. So you do not want to start a transport where you don't have good neck control with some type of helmet or device in place on the patient's head. Keep in mind that right mainstem placement is very common, as the angle of the right bronchus coming off the trachea is more straight, especially with new providers. So just anticipate, if you're intubating for the first couple times, you're going to end up with a right mainstem intubation. So pay attention to the depth of the endotracheal tube. When you auscultate breath sounds, sometimes the absent sounds on the left are very pronounced. Other times you can get some resonance transfer across the chest wall where it sounds like there's breath sounds, but if your endotracheal tube depth is like 26 or 28, you can pretty much guess that you're going to be in the right mainstem. It needs to be pulled back. So 19, 20, 21 for females, generally 20, 22, 23 for males. On somebody my size with an 8.0 tube, you could probably anticipate an endotracheal tube depth of 22 or 23. If I'm looking at Catherine sitting across from me, I'd be looking at like a 20 or a 21 with a standard 7.5 or 7.0 tube. Post-intubation assessment considerations. Let's talk a little bit more about complications and things you need to be starting to assess for if your patient's just been intubated, or you've performed the intubation, or you've just picked up the patient from the ICU that's been intubated, or the emergency room. So if the patient especially had any kind of chest trauma, they might have a previously undiagnosed small pneumothorax. The minute we add positive pressure ventilation to the lungs, those small pneumothoraces will grow into large pneumothoraces or turn into tension pneumothorax. So the transport nurse needs to immediately be able to identify those physiological indicators that are happening and react and act on those clinical situations. I've got a couple slides up. These are just very pronounced pneumothorax. The first one's a tension pneumothorax on the patient's right side. And you can see all the structures are shifted over to the left. We got the tracheal shift, the cardiac shift. So the physiological indicators on this patient, what we'd be looking for is increased heart rate, tachycardia, falling SpO2. On your ventilator, you'd be getting super high pressures. The very first thing you'd want to do if you're suspecting that, get the patient off the vent, attach a BVM, and assess your compliance of the bag. Was it as easy as it was when you first got the patient? Are there now changes that are going on? Auscultate the breath sounds. And then a falling blood pressure is a late sign of a tension pneumothorax. If you have the patient now hypotensive and hypoxic and it's a tension, you missed the boat. You missed all the early physiological indicators. The treatment for this condition is needle decompression of the patient. For pro-transport CCT operations, needle placement should only take place on an intubated patient. The risk of creating problems if you do the wrong side or you misdiagnose the patient is very minimal when a patient is intubated and you're doing positive pressure ventilation. If you have a patient that has developed a tension pneumothorax and the patient is not intubated, really need to think about those clinical indicators, make sure that they have the physiological signs that a tension pneumothorax is occurring before you shove a needle in a patient that's not intubated. You're then going to create a pneumothorax if you put it in the wrong side or you've misdiagnosed that patient, because now you're creating a hole where that negative pressure that's normally occurring, and you're going to get the air in there. So even though the treatment is needle decompression, if the patient's not intubated, make absolutely sure that this is a tension pneumo before you do that. With needle decompression, when I first started in my career, I was always very anxious about this because every textbook really emphasized about finding that intercostal space and getting over the top of the rib. And when I was in clinical skills, they would emphasize, make sure you scrape the needle over the top of the rib. And none of that ever made sense to me, and it really created a lot of anxiety for me. Until I had a call with a pediatric trauma, and my partner inserted that chest needle, and he was really emphasizing on getting that angle up over the rib, and we nicked the intercostal artery as he inserted that needle. And the patient began spraying blood out of their chest, and that's something that's always stuck in me. Whenever I teach airway courses now, I always use this picture, which shows the needle going through the intercostal space, and a lot of people don't know that there's blood vessels running through there. You have your blood supply intercostal arteries and the veins that are going right below the rib. If your angle of the needle is angled up, it's possible that you can nick those arteries and create a hemorrhage situation. So needle placement is just right through the intercostal space. Not so much emphasis on angling up or scraping the rib or anything you may read in a pre-hospital care book. The needle size that we use is a 10 gauge or a 12 gauge. Your target's going to be the second intercostal space, mid-clavicular line. There's also a couple other sites as alternatives. So the standard first choice would be second intercostal space, mid-clavicular line. That's represented on this slide by A. The next one is going to be mid-axillary line, and this is really taking favoritism with a lot of providers and emergency docs, because if you think about it, especially on somebody like a male, I'm not well developed in the pecs, but there's enough meat there that if you're trying to insert a needle through my intercostal space, you're going to use a lot of force to try to get through that muscle tissue, and it'd be very difficult. Sometimes nurses I've assisted can bend the needles and not get it in all the way, trying to get through that muscle tissue. So one alternative is the anterior axillary line, which goes below the muscle tissue, and then the mid-axillary line, and those are fourth and fifth intercostal spaces. The slide to the right can show you how, if you have a pneumothorax, placing that needle gets into that void and can help with air escaping to relieve a tension pneumothorax. Monitoring our patients, again, like we said in the preparation stage, you have your monitor set up for every 3 to 5 minute vital sign monitoring. You're constantly reassessing the patient for problems. These are just great examples of what can happen and how to anticipate changes during a post-intubation phase. You can see the patient's newly intubated. We got a good end-tidal CO2 waveform with good numbers, and then suddenly the patient becomes bradycardic. You can see our ventilator still there. Our blood pressure has fallen off into the 60 systolic with a heart rate of 32. So went from what's on the left to what's on the right. We already have our IVs established. We can start our fluid boluses. We can give our atropine, but these are different things that you anticipate that can happen shortly after RSI. They don't happen all the time, but these are things you're prepared for so you can immediately react when they do happen. And I wanted to include these two pictures because this is on board an ambulance. This can happen in the CCT environment. Let's move into our rescue airway section. For rescue airways with ProTransport, we're using the iGels. Some of the EMS community in our area here in Northern California, I've noticed the King Airways are still in play. With our company, we are using the iGels. They come in various sizes. On the ambulances, they don't go down to the infant sizes. I believe we start off on the 2.5 up to the 5. The 1 and the 1.5 will be carried by CCT nurses for pediatric infant transports. So those will be in a special bag that we'll set up. The iGel Airways are weight-based and color-coded. It's very clear on the packaging what the weight is for that patient, and just a quick estimation if you're not sure will get you by. There's a horizontal marker that you insert down to the teeth. Just one key point would be to lube up that airway as you're inserting with the provided jelly that comes in the packet. Otherwise, it can hang up on the tongue and create problems. This is a great video that's used for the EM Crit site. London Ambulance Service does a great video of the iGel insertion that's pretty short and quick.
Moving here, keep going, yeah.
First, decide on the most appropriate size of iGel O2 to use. Correct size is normally determined by weight. Open the iGel O2 Rhesus pack. Remove the inner tray containing the lubricant, airway support strap, and suction tube, and place the contents to one side within easy reach. Place a small bolus of lubricant on the base of the inner side of the main shell of the packaging. Touching no lower than the bite block of the iGel O2, lubricate the back, sides, and front of the cuff with a thin layer of lubricant. Ensure any excess is removed. Grasp the lubricated iGel O2 firmly along the integral bite block. The ideal patient position for insertion is with the head extended and the neck flexed. But if this is not possible or is inappropriate for the patient, then iGel O2 can be inserted with the head in a neutral orientation. A proficient user can achieve insertion of iGel O2 in less than 5 seconds. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. It is not necessary to insert fingers into the patient's mouth. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force. The tip of the airway should be located into the upper esophageal opening. The cuff should be located against the laryngeal framework. The epiglottis should be held in place by the epiglottic rest. The gastric channel should open into the esophagus, and the incisors should be resting on the integral bite block. The iGel O2 should now be secured in place with the airway support strap, or taped down from maxilla to maxilla. To use the airway support strap, slide it under the patient's neck and secure it to the iGel O2 hook ring using the appropriate holes on the strap. Ensure there is sufficient tension to hold the iGel O2 securely in place, but not excessive tension that may cause trauma to the patient. Some adjustment of the strap may be needed. A resuscitation bag can then be connected to the iGel O2 and ventilation can begin.
Okay, so we just finished the video about the iGel insertion with the London Ambulance Service. Then let's talk about our failed airway management. And at this point, you're probably overwhelmed in this presentation. And you may be thinking, like I said at the very beginning, why in the world do we need to learn all these skills? Everything that I get or need, I get at the hospital, I put the patient in the ambulance. It's very unlikely that I will encounter any of these. So part of ProTransport expanding services and working with different medical centers is that we will be taking higher acuity patients. And again, like I emphasized, sometimes it's easy to become complacent in our industry. You show up to work and it's difficult to find the time to promote your education or to get in and want to learn new things about your clinical practice. But the standard I want to emphasize in all the counties of this area is that our nurses are providing basic ALS level care, which includes intubation, being able to manage a code on your own, all the emergency medications that go along with that. So it's really important that you are up with the latest and the greatest of what's going on. And as we move into this transition period with ProTransport and the types of patients that we are transporting, the responsibility of the nurses and the accountability is going to be a little bit greater. The other thing that I'll point out is that, especially coming from the flight side, We're going into fall and the weather season is supposed to be rainy, hopefully in California this year. So as helicopters are grounded, medical centers look immediately to ground CCT to get those stat or critical patients out. And ProTransport Management's looking at that, how we can respond to those emergency stat requests, especially in those rural areas like Merced or Mariposa or these other outlying clinics where patients are not able to get those resources at those smaller clinics or medical centers. The responsibility will fall on us to provide that level of care and bring the equipment and on that level of care to those other medical centers. With that, let's move into the failed airway where we can't ventilate, can't intubate the patient. We'll talk a little bit more about that. So what exactly are we going to do? I've mentioned several times that we need to put something through that cricothyroid membrane, but what exactly am I talking about? Thinking of a surgical airway, that's pretty darn scary, that you're going to take a scalpel to somebody's neck, and that can be very anxiety producing for a nurse if you're code 3 down the back of a highway trying to figure out what the next step is. We're going to discuss surgical airway. We're going to demonstrate those skills on some tracheas that we have so that you're familiar with those. I'm not exactly quite sure what Dr. Wolf is going to approve for our program. I would suspect that at the minimum we'll have the Quick Trach 2, the video laryngoscopy, although a surgical airway and how those are performed is still vitally important for the CCT nurse. For a surgical airway, again, this is for the can't ventilate, can't intubate situation. The patient is going to die unless you take immediate action. Surgical airways are performed on adult patients, basically anybody over the age of 8. I've run into situations where you may have a 6 or 7-year-old that looks like an 8 or 9-year-old. So this is kind of where we get into those gray areas of our practice. So default to always what's best for the patient. If you are ever in some intense situation where a patient needed a definitive cricothyrotomy, airway, and it's a 7-year-old, but the protocol black and white says 8, nobody within ProTransport Management will fault you if you do what's best for the patient to try to save their life, oxygenating through a cricothyroid membrane insertion device. On this slide, we're looking at great anatomy of a pediatric patient that has upper airway issues. They defaulted immediately to cricothyrotomy. This is going to be a can't intubate, can't ventilate situation on this child. What's great about this slide is it gives another great detail anatomy picture for you. On the left, we can see the thyroid cartilage where the cricothyroid membrane is in relationship to the cricothyroid cartilage. And then to the right, we have the actual anatomy of those processes. We can see where they did the initial needle percutaneous stick through the cricothyroid membrane, and then they opened it up for a tracheostomy. But you can see how the upper airways are involved for that. The upper picture, you can see the endotracheal tube going through the cricothyroid membrane for the surgical airway. This is a video of the Quick Trach 2 insertion. The Quick Trach 2 device is fantastic for nurses because we're used to threading IV catheters into patients, and it works similarly to an IV catheter. You do a percutaneous stick through the cricothyroid membrane after you identify the membrane, and then thread the cannula into the trachea. So this is a very quick video on the Quick Trach 2 operation.
The Quick Trach 2 is a set for percutaneous cricothyrotomy according to the catheter over needle technique. The sterile set is pre-assembled and immediately ready for use. Hyperextend the patient's head. Locate the cricothyroid membrane by the palpable depression between the thyroid and cricoid cartilage. Stabilize this site with index finger and thumb. Puncture the cricothyroid membrane in a 90-degree angle and insert in a 45-degree angle in caudal direction up to the stopper. The stopper helps to prevent the needle from being inserted too deep, helping to avoid a possible perforation of the rear tracheal wall. Aspirate air with a syringe to determine the position of the cannula. If this is possible, the needle tip is in the trachea. Remove the stopper from the cannula and push the plastic cannula forward with the thumb until the safety clip audibly clicks into position. This indicates that the tip of the metal needle is covered by the plastic cannula to prevent trauma. Further insert the Quick Track 2 until the flange is flush with the patient's neck. Then, remove the metal needle from the cannula. Inflate the cuff with the prepared syringe. Secure the plastic cannula with a foam neck tape. Ventilate the patient directly via the 15 mm standard connector or via the included connecting tube.
Okay, so we just watched the video on the Quick Track 2, great device. Let's move into some more transport emergencies that CC2 nurse may encounter in our environment. So one of the leading ones is accidental extubation in the transport world. In my 18 years, I've only had one accidental extubation, and it was quite the experience when you see the patient coming out of the back of the helicopter, and then you see the retention balloon of the ET tube sitting on their shoulder. So the ventilator tubing got hung up on something on the floor and extubated our patient. That can happen very easily in an ambulance environment, helicopter. So accidental extubations happen, and you need to have the equipment and be prepared to get the patient re-intubated, either through full RSI sequence, or if they're heavily sedated already, you might be able to just do a full-on laryngoscopy with video laryngoscope. Partial ET tube dislodgement, we've already kind of talked about, but I put a reference slide up here to show you how that can happen, where the ET tube is partially in, yet partially out. You're getting intermittent waveforms, or they're just not oxygenating well. If you have any question of this and you're in the back of the ambulance and you're trying to troubleshoot, there's absolutely no harm in grabbing a laryngoscope if your patient's sedated, grabbing a video laryngoscope and going in and looking to see exactly where that tube is. Again, direct visualization with the waveform capnography, those are our gold standards that endotracheal tube is sitting in the trachea. The other thing that we may encounter commonly, especially in the pro-transport environment, we do a lot of tracheotomy transports where the trache's usually been in for a while, but it could be in fairly recent. It could be a fresh trach. So tracheostomy obstructions or tracheostomy dislodgements. So that's what I'd like to talk about next. So let's go over tracheostomy emergencies because this is highly probable in our environment. Any patient that's on a ventilator must have end-tidal CO2 waveform capnography by our company standards. You want to make sure you get printouts when you first pick up the patient and when you drop them off with that waveform capnography. Assures that that device is in the trachea and functioning normally. Whenever you have an emergency with a tracheotomy or tracheostomy, we're going to follow the dope mnemonic that most of the ABC courses follow, which is displacement, obstruction, consider pneumothorax or equipment failures. Our slide reference here is just to get our picture of where we are with the tracheostomy. Tracheostomies are below all of the cartilages that we are talking about. It's below the cricothyroid ring. So for our purposes with the cricothyroid membrane, when we're talking about emergency measures, as a review, we were talking about that cartilaginous ring with the thyroid and the cricoid cartilages. For the tracheostomies, we're well below that. We're in the actual trachea with the fibrous rings that go around. That slide references that. So our steps, what do we do if we have a tracheostomy emergency? So the very first thing that you'll want to do is if there's any caps or any kind of things hanging off there, any extra filters that you have, anything that's on that device, remove all of that so that you're just left with the obturator assembly and the device. Remove the inner cannula and deflate the cuff. You're going to want to apply oxygen to the patient's mouth and to the tracheostomy. One thing to consider is you can get the nasal cannula, so by mouth I'm meaning non-rebreather mask, or you could do the high flow nasal cannula like we discussed during the pre-oxygenation phase for RSI. That would be a great option with an oxygenation emergency with a tracheostomy. The next thing you'll want to do is try to pass a device through that obturator assembly. So a suction catheter is what you want to shoot for. A great sizing trick is 2 times the size of the tracheostomy. So if you have an 8.0 Shiley or something to that, you just multiply by 2 and you'd be looking at a 16 French catheter that you'd want to place through. If all those efforts are failing, one thing that you'll want to do is try to ventilate through that ostomy hole, and you can achieve that by using a pediatric ambu bag or an infant ambu bag, or another trick is to take an iGel Airway, the smaller size, and push the iGel Airway over that stoma or the tracheostomy site and ventilate through that area. Additional interventions. So we're running into a problem with ventilating. So the very first thing that we'll want to do is to try to change out that tracheostomy. If you brought an extra one with you, you can change out the whole obturator assembly or just the intercannula to eliminate that as an obstruction. We want to extend the neck out, use a little bit of lubricating jelly. For most of our patients, the channels are well established and we can quite easily change out those obturator assemblies. You can also try initially changing out that intercannula to eliminate that as a potential problem. If that fails, your next step is going to be to try to use a smaller size tube. That may be problematic if you're on a transport and you didn't think to grab a smaller obturator assembly. In the hospital environment, this is a little more practical. But if you have it available, if you had like an 8.0, then a 7.5 or a 7.0 inserted into there would be the next step. Again, the third intervention, thread that suction catheter through the smaller tube, and then what you could do is thread an obturator or intercannula over the suction tube. You're kind of using it as a bougie to help guide that in. So those are 3 different options that you can do on well-established airways. Where we run into problems is if the tracheostomy is less than 7 days old. Then you run the risk of pulling that out and having the tissues close around, or if you try to insert a different airway, you can create a false channel because the surrounding tissue is still soft and friable. So you really run into problems if the trachs are less than 7 days old. If the upper airway is patent, so these are 2 other questions that we need to ask ourselves with tracheostomy emergencies. If the upper airway is patent or if the upper airway is not patent. So if it's patent and the patient just has a simple tracheostomy and all the anatomy still exists, like they have a glottic opening, they have all that other stuff, then you can manage this patient by ventilating through the mouth, BVM. You could consider video laryngoscopy and then cover the stoma hole or the tracheostomy hole for a full-on intubation in those kind of patients. So you can ventilate through the mouth, cover the stoma, and deal with the emergency in that way if the anatomy is in place. If the upper airway is not patent, they've had a full laryngectomy, all the anatomy is gone. Normally, the trachea is sealed off up here, then ventilating through the mouth and nose will be futile. You're not going to get any kind of ventilation going through there. So then those patients, your only way to intervene is to ventilate through that stoma hole that you have. I've put some pictures up there. You can ventilate again with the pediatric mask or with an LMA to try to get a better seal around there. The material of the, not LMA, but iGel is a lot more conducive to ventilation and getting a really good seal. The next thing that you could possibly do is to intubate the stoma hole. And to do that, you would utilize a bougie device. So through the stoma hole, you've gone through the 3 interventions, everything else has failed. The suction catheter that you've thread through, you've changed the intercannula out. If you had it, you changed the obturator, none of those are working. So then our last step, the last thing that we would do is just intubate the trachea with what we have. You would take a flex guide or bougie, you'd thread that in carefully, not making sure not to create a false track. And then you take a 6.0 endotracheal tube and thread that over your bougie and get that in and inflate the cuff. Then you should be able to ventilate the patient through the endotracheal tube that you put in. This is a great slide of a tracheostomy in an infant. One thing I wanted to point out here are what's called stay sutures. So stay sutures are put in fresh trachs less than 7 days old, and they have the retention sides on both. For pediatrics or infants, the stay sutures may sometimes just stay in. So in emergency conditions, in those situations, you would not remove that obturator assembly where the stay sutures are. So pay attention if you've got stay sutures on either side, do not remove that. So that's how we would deal with any kind of tracheostomy emergencies. And again, if the patient has a tracheostomy with the cannula in place, they have to be on end-tidal CO2 if they're on the ventilator. We've talked a lot about the video laryngoscope, and I've mentioned Vivitrac a few times. So I'll go ahead and show the Vivitrac introduction video and introduce the Vivitrac video laryngoscope. It's super compact, it's very easy to use, and this is just a quick down and dirty video of how the Vivitrac works.
Vivitrac comes in a medical clean packet that looks like this. When you take it out of the packet, you will notice that the USB cord is attached to the device. You will notice the stainless steel blade and the channel on the right. To load it, you take an endotracheal tube, you lube it quite generously through the balloon and all the way to the marker. To insert it, you turn the tube 90 degrees and put it into the tube channel. You let the channel guide where the tube is going to go. The proper alignment of the tube is to be at the distal end tip of the device. You plug it in, and you can plug in the USB cable to any USB port. Here I'm plugging it into an extension cord, USB extension cord of the ViVision tablet, which is ours. As soon as you plug it in, you will see that the image comes up on the screen. While looking in the patient's mouth, holding the device with the index finger on the top of the device, the thumb on the back, and your middle and ring finger on the front of it, on the blade part, you put the blade facing straight down into the patient's mouth. You place it such that the body of the Vivitrac device is resting on the patient's chin, and you want it quite snug on the patient's chin. In that position, following the natural curvature of the roof of the mouth, you insert the device into the mouth. As soon as the cord comes into view, you take your right hand with your endotracheal tube. If you need to, you turn it counterclockwise to turn the tip to the left, and you intubate. As soon as you see the balloon go through the cords, you want to release the ET tube by pulling it forward and to the right. You hold the tube onto the right, and to release the Vivitrac device, you reverse the process of insertion, just like that. Then you can blow up your balloon and secure your airway. As you can see, this should take no more than a few seconds.
Okay, so we just watched the video on the Vivitrac. So a couple advantages to the Vivitrac. We talked about the C-collar in place and intubating patients. Again, C-collar can remain in place if you're using a video laryngoscope like the Vivitrac or GlideScope. So we'll be using the Vivitrac device. So it can help get you around position obstacles. You can directly visualize the airway, and what's great about Vivitrac is as soon as you plug it in, it begins recording. So there's a medical record of your intubation attempt. We can see the tube going in through the trachea. The Vivitrac device is disposable, and it comes in pediatric and adult sizes. One thing to remember about Vivitrac is you don't use it like a traditional laryngoscope blade where you're going to move in and push the airway structures up. The Vivitrac is designed exactly like an oropharyngeal airway. So the angle is exactly the same. So the insertion is almost the same as an oropharyngeal airway. We just insert it straight down, and then as it seats down into the airway, 80% of the time, your airway structures will come into view. So that's what's great about Vivitrac. Here's a quick video to show the ease of use. This is a nurse on board CCT ambulance with a stroke patient that deteriorated that now needs to be intubated during the transport. This is the first time using it on a live patient. We can kind of talk through this attempt. You can see that she's going down, getting tongue control, having some issues there, not sliding past. We're starting to look for our anatomical structures. We're moving back into the oral pharynx. She decides to take her finger and kind of push the tongue out of the way, and it snaps the airway structures right into view. We got a great view of the airway. She threads the bougie down through that glottic opening. There's a critical mistake that's about to happen that I'd like to point out. Even though she's doing a fantastic job, she had identified all the airway structures around that trachea. We're starting to thread the endotracheal tube through, but then she gets distracted. She looks away, and as she looks away, the blade gets moved. So as the blade moves, we lose visualization of the airway. What saves the whole thing is that the bougie's in place. We're able to continue threading that endotracheal tube down over the bougie into the airway and successfully intubate the patient. So great example, great intubation, really quickly shows how easily you can get distracted and it can alter what you're doing during airway management. I've had a few nurses ask me if I could cover airway obstruction. They always see the McGill forceps in the packs, but nobody really talks about how the McGill forceps are used. So in the skills section, we'll cover that. These are a few examples of airway obstructions that you can encounter if you get in with a blade. Pediatric patient on the left with some type of debris that's covering the glottic opening. And then the one on the right there is a chicken bone a fish bone that got caught in the airway. McGill forceps are angulated so you can reach down into those airways near the airway structures and grab any kind of obstructions. And we'll cover that in the skills section. They come in 3 different sizes. There's an infant, pediatric, and adult. We carry pediatric and adult McGill forceps. All right, so then one of the last big topics that we'll talk about, we talked about reviewing all the skills. Quick trach, we talked about video laryngoscope and all the other devices that we have. So the last thing to kind of go over, again, not sure if medical director is going to add surgical airway, but it's definitely really good to talk about and go over the different procedures as these are done by emergency room physicians in those can't intubate, can't ventilate situations. So surgical airway or surgical cricothyrotomy is when we're actually using a scalpel to cut into the cricothyroid membrane. So how do we do that? How is that done? Most flight crews are still trained in doing this. I'm not familiar with CCT programs that are actually doing scalpel surgical airways at this time. Again, this is only done when all other efforts have failed, have been unsuccessful. The patient is going to die unless you're taking immediate action to gain airway access and get the patient oxygenated. On the slides here that I've got up, just a couple anatomical reviews as it's related to this. For surgical airway identification, we're looking at the thyroid cartilage at the Adam apple or just below the thyroid prominence, and that leads us to the cricothyroid membrane, and that's our target. Below the cricothyroid membrane is a cricothyroid ring. So we want to be above the ring, below the Adam's apple or the prominence. The only thing that you need for a surgical airway, what makes it so simplistic, is you can get away with just doing a scalpel, a bougie, and a 6-0 tube. You could actually forego the tracheal dilators, all the antiseptic, and in a bona fide emergency where somebody is near death, a surgical airway can be performed very quickly to gain tracheal access. So for step 1, we would extend the neck. We'd palpate the anatomical landmarks. We want to identify the cricothyroid membrane, which I was discussing. The big thing is stabilizing the thyroid cartilage. Once you identify your landmarks, we stabilize the thyroid cartilage, and then we use our index finger to palpate the membrane, and then we don't move, stabilizing that cartilage. We take our scalpel, it's just a couple quick cuts through the skin into the connective tissue. Again, our finger is right there over the membrane. We make a plunge cut through the membrane and then rock the scalpel back and forth to rupture that membrane around the cartilaginous ring, and then that opens up the cricothyroid membrane. For emergencies, physician or nurse may use an index finger that's right there to shove that in the hole that's just been made, or you may use a tracheal dilator, trousseau dilator. I've seen where the end of the scalpel's just been flipped over and the scalpel's been spun around into the cricothyroid membrane to enlarge that hole so that it accepts a bougie or an endotracheal tube. The goal is to just get the opening dilated. Ideally, you want to insert a bougie with the coude angulated tip so that you don't create a false channel. So the coude angulated tip is then inserted into the trachea, and once it has reached the end or a hold, then the endotracheal tube is threaded over the bougie into the trachea. So credit to Scott Weingard on his EM Crit website. He has a fascinating video. It's the best one I've seen of an actual surgical airway being performed. This was a resident in an emergency room. The background on this patient was EMS brought this patient in cardiac arrest. He had multiple cardiac arrest events. They got Ross back. In the emergency department, they had another cardiac arrest event back. They got him back. He's on an amiodarone drip. And for some reason, I wasn't quite clear, his jaws were wired shut. He was a can't intubate, can't ventilate type situation. They put him on BiPAP or CPAP for positive pressure. They were able to get some ventilation support on that, but definitely needed a surgical airway to gain airway access. So this is that video.
Oh, yeah.
I think he's refilled.
I saw him.
We don't have a great way for him then. Is he on the pad? Is he on pads?
No, they took them off.
Has to be.
I think he needs to be shot.
Yeah, she definitely.
Wait, I gotta put the pad on.
Yeah, he's going through. Okay, let's put the
Feel the membrane there?
Here, Doc, can you put this on that side?
on the.
So you can take the towels away. That's
Doctor,
no longer
can you
doesn't need to be
reach
sterile.
under Dr. Correct and put this?
Just take the picture.
Yeah,
this is here.
I don't, I can't.
Finger in that. Put your finger in that rum.
Wait, I'm not in.
I'm not good.
I get some gauze.
Okay, don't need to see anything. Get the
Here's
bougie.
your gauze.
Need a bougie.
Through here.
Leave your finger in, trying to see if you can get with your finger in there.
Looks like he's
So that way you know
more-
it's going in the right place.
You gonna resistance? Resistance? Okay, good.
Charlie?
Get out.
I don't know if you were going to be able to fit
What was
that
the
one.
internal?
I have it here. I have it here. But you don't need it right now. Okay.
Wait, can you get some lube? Do we have any lube? It's gonna be hard to force that through.
Surgery loop.
Click up the surgery lube.
It's in.
Oh, you got it?
And you can take the bougie out.
Inflates. Inflates.
I need a 10 cc syringe, please. Here's your inner cannula. I don't know the vent settings.
All right, so that was a great video, great surgical airway video. Just a couple things on that video. That was the physician's very first time doing a surgical airway, so kind of explains the multiple cuts, and he goes on to explain on the video that's available on the EMCrit website a little more about the patient's condition and details. So one thing to point out is he's using his index finger to find the anatomy, and once you find the anatomy and do your cut, it would be very important that you don't remove your finger. You don't want to lose that hole that you've just made. It's very easy for the tissues to close up, or you get a lot of blood that's pooling in the airway, and you can lose your anatomical references and then insert a bougie into a false track. So very important if you were to find yourself in those situations. So key points to remember about everything that we've kind of talked about today is be methodical and decisive without any hesitation when it comes to advanced airway management, especially in the ambulance when you find yourself by yourself and you've got maybe a couple inexperienced EMTs. Maybe this is their first CCT and then you're dealing with an emergency. So distractions, whether it be with the patient or distractions with your surroundings, tune everything out, focused on what you need to do clinically and make those decisions. Don't hesitate. One thing to point out is with everything that we've covered, all the assessment techniques, the different mnemonics, the DOA, the lemons, the moans, it's impossible to predict with certainty that you will have a difficult airway. All we can do is plan for a failed intubation. You have to be ready to carry out a plan. You should always have a backup plan ready, even for standard intubations. If you were intubating my daughter, who's perfectly anatomically on the video, looks great, you should always have a backup plan available for any patient. Be ready to immediately carry out the plan in case you have a failure. Always have a backup plan. Make sure that you're initiating rescue maneuvers early so the patient has enough reserve. We talked about clinical situations where the end tidal CO2 starts dropping off. You may have a partial tube dislodgement. Now your SpO2 starts ticking down and you're wasting precious time trying to figure out, okay, is it in, is it not in? I'll jiggle this or check the monitor one last time. And in all those times, you might be able to do other definitive interventions that can improve the patient's condition. Don't waste time, don't hesitate. Initiate rescue maneuvers and interventions early. Other big points to take home from this presentation would be the pre-oxygenation phase that we talked about, and a lot of that goes to the bag valve mask seal. Make sure you're using 2 people when you're actually ventilating somebody. One person that's just dedicated to that mask seal, and if you're using a PEEP valve and you're creating that level of PEEP, really oxygenating and maximizing your ability to oxygenate the patient. Make sure you're communicating to those people that are helping you. Make sure you're using a checklist. Make sure you're using the RSI cards. This is not the time where you'd want to pull out your phone and try to find your app that you're on real quick and then do the mathematical calculator to try to figure out your drug dosing. This is where you pull out the reference card, you look at the weight, it tells you the dose, and that's what you do. So checklist and the RSI reference cards that we provide. Again, reassess frequently. You're constantly monitoring your patient's vital signs, you're monitoring your ventilator, you're monitoring your airway status, and immediately act, especially with that end tidal CO2 waveform. Any variations with that, the waveform's dropping off, it's starting to become dampened. Anything that's happening with the end tidal, you need to react to immediately. And don't forget, another option that you have is a contact clinical management. Contact your resources that are available for clinical guidance or a second opinion. So finally, our patient care guidelines and clinical protocols will be coming out in the next couple months. We'll be doing our hands-on skills evaluation with Dr. Wolf, our medical director, who will be evaluating everybody. Everybody will have to be signed off with approval of the medical director, and we'll be rolling out exactly which skills that we've covered today that will be implemented within our company. Again, if you've watched this video and you're from a different company, make sure you're checking with your local protocols, you're checking with your local medical director for what you do within your program. Thank you everybody for taking the time to learn everything with ProTransport. Thanks for dealing with me for the last couple hours in our airway management, and a thumbs up from my daughter for sticking it out through our program. Thanks again. All right, so here we are with our skills presentation, kind of summarizing everything that we talked about during the PowerPoint slides. We're going to review some of the basic techniques with the equipment that we carry with the ambulances and ProTransport CCT. Again, if you're with a different program, the equipment may vary, but here's hands-on practice with those skills and what we'll be going through with the clinical scenarios during your skills day. So with our airway mannequin, let's go ahead and talk about just the pre-oxygenation phase and the importance. With pediatric patients, we were talking about the C-clamp on the mask and the importance of not ventilating. The oxygen tubing would be connected to high flow oxygen, again, 15 liters or 25 liters if you can, the highest flow that you can possibly get, and we're pre-oxygenating our patient. And then when we have a second person for an adult patient and we get a good mask seal, that one person, their entire focus is on pre-oxygenating, holding that mask on the airway to get great seal. We would have a nasal cannula coming off at 15 liters if possible, everything that we could possibly do for that nitrogen washout phase in pre-oxygenation. We've already assembled all of our supplies, so we're past step one. Pre-oxygenation phase is where we are. All right, so as we get to pre-oxygenation, the other thing to think about is if this is a difficult airway where the patient's semi-conscious or a crash airway, then we'd want to go ahead and escalate to an airway adjunct, nasopharyngeal airway or an oral airway. So let's go ahead and insert that. Shall we do that real quick? So for a nasal airway, we measure from the tip of the nose to the tragus of the ear for sizing, and then that just gets inserted with the natural curve down into the nasopharynx. We can use that on conscious patients with a gag reflex. For unconscious patients without a gag reflex, we go ahead and move into our oral pharyngeal airway from the corner of the mouth to the angle of the jaw for the measuring. And then you can do a side-in rotation, or if you can make sure that you're not getting the tongue pushed into the back of the oral pharynx, we can just do a standard rotating in. Let me get that seated just a little bit better for us. Okay. Then our assistant would go ahead and continue on with the pre-oxygenation phase. All right, so now let's go ahead and move into, we would have our pre-medication and our paralytic and induction. We're going to move past the medications and just get on the hands-on skill portion with the intubation. So we have a variety of blades available to us in our intubation role, the Macintosh, the Millers, all the way down to infant. Our ET tubes come prepackaged with a stylet already in place. What we'd really like to emphasize with clinical education with our company is the use of a bougie with every single intubation. It's a lot easier to manipulate this smaller diameter device in through the airway, and it's a lot more forgiving than having a rigid stylet placed through an endotracheal tube and dealing with the weight and the diameter. So it's a lot more user-friendly, especially for new intubators with the flex guide or bougie. Again, gold standard would be the end-tidal CO2 waveform capnography immediately after intubation. We also have a colorimetric color changing device. Again, purple means problem, yellow is okay. So no color changes, you definitely have a problem, but the default gold standard end-tidal CO2 waveform. One tip is to always make sure this is hooked up to the monitor on the Zoll, ready to go and warmed up. You need to make sure that you are having this in place and warmed up. Otherwise, you'll have a big delay of about 30 to 60 seconds as the end tidal warms up. All right, so now we'll move into our intubation. Our patient's pre-oxygenated. We would go ahead and remove our oral airway. Nasal airway could probably stay in, but we'll go ahead and take that out. As we insert our blade, again, we're taking a deep breath, just slowly and methodically. New practitioners will instinctively want to hold the blade like this. This doesn't provide you the leverage or the control at the tip of the blade. So what you want to do is slide your hand down so that you're actually putting a couple fingers on the blade right here at the angle, and you can control the blade a lot better. For adults and large pediatrics, and if you're a new intubator, I would always recommend that you use a Macintosh blade. A Macintosh blade is designed so that you can obtain really good tongue control, move the tongue and sweep it off to the left. as opposed to a Miller blade, where a Miller blade is straight on and it's very difficult to get tongue control and manipulate. So to clear the airway, maximize oropharyngeal visualization, a Macintosh blade is the best. This is a Macintosh 4 blade, and even if it's too large, I can pull it back and make it into a Macintosh 3 blade. So we insert the blade, we're slowly going down past the tongue. I'm looking at the posterior oral pharynx now on the mannequin. I'm talking to my partner about the anatomy that I see. The epiglottis is coming into view, and now I've got good visualization of my anatomy. I'll go ahead and thread my bougie through the airway and then thread my endotracheal tube. Notice just instinctively over the years, I tilt my blade just a little bit and it's opened up the oral pharyngeal view that I have. And then if I had an assistant pull or tug on the cheek, that also increases my working space. So my endotracheal tube is going to go through. Okay, now I've watched that go through the glottic opening. I slowly pull my blade out. The bougie comes out. The tube's inflated, and then we can start bagging. Okay, so now we would go ahead and secure our airway with our endotracheal tube holder. The pilot balloon should come up to the top so it doesn't get pinched in the holder. I verify my tube depth, so we'll say 21. This tube holder has a bite block built into it, so the bite block goes in first. We seat that onto the patient, thread this around their neck. With the securing device, it comes up through the channel. Then you pull up and snap down into the retention hole. All right, so we verify everything is seated correctly. The tube depth has not changed, and then I'll go ahead and clamp this down and secure my tube without pinching my pilot balloon into that. Again, like I had mentioned, this AMBU device is designed to pinch the tube just a little bit. You'll see a little bit of tube deformation, and that's perfectly normal. Gold standard again, waveform capnography. We get this on right away, and we're looking for our end-tidal CO2 waveform to confirm placement. Auscultate bilaterally, equal breath sounds, equal chest rise and fall. Make sure you auscultate over the epigastrum. Even if it just seems redundant, you may think I've got good breath sounds. Always make sure you're in the habit of doing that. The tube is secured, it's not going anywhere with this device, and we're good to go. The next step would be to go ahead and set up my ventilator. 6 to 8 mLs per kilogram on the tidal volume. Again, default. Always 100% FiO2 for emergency intubation situations. And then that's pretty much it. All right, the next thing we'll talk about is a rescue airway. So this falls into our crash airway, failed airway algorithms, can't intubate. We're gonna default to the epiglottic airways. We use the iGel at ProTransport. Again, weight-based like you saw in the video. Just super quick, super easy insertion. Make sure you're using the lube that comes with the package. We have the headset with the lubrication. That's the critical step, and it just easily gets inserted. Studies show that the iGel asserts a force of about 30 millimeters of mercury across the glottic opening, which is great for securing the airway. Although it's not definitive airway control, because it's not securing the trachea from secretions or gastric regurgitation, we are able to ventilate with the rescue airway like this. Also keep in mind that it has a suction cannula hole, so we're able to do gastric suctioning through the iGel, which is a great added benefit. Okay, the next thing on the skills we're going to talk about is the situation you may run into in the ambulance. You've picked up an intubated patient, you're transferring, and the ventilator may show low pressure, may show disconnect. You're getting repeated alarms, you've troubleshooted, you can't figure out exactly what's going on. Following our dope mnemonic, we go back through and we can find that our retention balloon for the endotracheal tube will not hold air. We've tried a couple times to inflate the cuff, but with that situation, we know that our retention balloon has a leak. So we'll need to go ahead and change out the endotracheal tube. We're assembling all of our supplies. We have our replacement tube ready. We would inflate to make sure that the balloon's intact on our new tube. We take our bougie device. We want to make sure that we're using the straight end, not the coude end. The coude or curved tip is not going to work in this situation. It'll create resistance in the airway. Use the straight end. It's going to go right into the old tube. We're going to follow it down to the channel until we reach hold and resistance. Then, with that balloon that's already deflated, we're going to carefully pull up the old tube. As we reach this point, I want to reach down right away and stabilize the bougie, pull the endotracheal tube off. While continuing to stabilize the bougie, I have an assistant thread the new tube over. And then once we get to the point of my fingers, I'll take control of this endotracheal tube and then slightly glide the endotracheal tube through until our previous depth is achieved. Then we'll inflate the retention balloon on the new tube, remove the bougie, and then ventilate the patient. And a quick change out of an ET tube can be done in like 30 seconds. Super easy procedure. Another little tip, it would be perfectly acceptable to grab a laryngoscope during the change out, and as we're threading the new tube through, you can pull the tongue and these airway structures out of the way with the laryngoscope as you're threading the new tube through. So that's an alternative that would be perfectly acceptable to do in this procedure. All right, back to our skills. For this, we're going to talk about the Vivitrac, the video laryngoscope. One thing to point out with the Vivitrac is the angle is exactly the same as an oral pharyngeal airway. You can see the curvature, and so the insertion is very similar to an oral pharyngeal airway. Setting up the device, we have the channel here for the endotracheal tube. So we'll seat the endotracheal tube in the channel. You'll want to lube this up with a little bit of lubrication so that it slides off once you get into the airway. With the bougie, use the straight end, not the coude curved end. We're going to thread that down through the endotracheal tube, again, right to the end. One tip is that you don't want to extend past the end of the Vivitrac. If you do, it's difficult to manipulate the endotracheal tube and the bougie in the airway. The next step is to go ahead and connect the device up to our tablet. It will immediately turn on and start recording. Okay? Then placement of the blade is just straight down. The key thing is not to push the tongue into the back of the oral pharynx. We just slide it gently down past and over the tongue. You'll probably need to pull up on the blade just a little bit or manipulate the blade back to visualize all your anatomical structures. All right, so the next clinical skill we're reviewing is the jet insufflator with the percutaneous needle going through the cricothyroid membrane. So we have some pig tracheas, which are fantastic for anatomy. They're almost identical to human anatomy. We have the cartilages around the glottic opening with the epiglottis here. Moving anteriorly, thyroid cartilage, cricoid cartilage, and then the cricothyroid membrane. Pigs even have a small Adam's apple. There's a bony prominence here, just like a human. So identifying the cricothyroid membrane is what we're looking for. My assistant assists with this skill. So we'll take our percutaneous needle. This is a 12 gauge 3-inch specialty needle that's in our kits. We'll attach a syringe. And then the big step is going to be identifying the anatomy again. Stabilizing thyroid, cricoid, then right in the middle below the bony prominence is our cricothyroid membrane. We'll go ahead and take our needle and puncture the membrane. The membrane is very thin. You'll go right through it just like a knife, like butter. We'll go ahead and aspirate to make sure that we're in the trachea. I'm getting nothing but air. So I'll remove the needle. Then we'll grab our jet insufflator, attach this to our needle, and then We give puffs of air till chest rise is achieved. So a puff of air until you see chest rise. And that is a jet insufflator. A couple points. It's very difficult to try to tape this down. You'll have to have one crew member that's dedicated to only stabilizing this catheter to assure that it's not moving around, especially in a moving ambulance. So kind of problematic, but achievable. All right, the final skill we're covering today from our PowerPoint is dealing with tracheostomy emergencies and ventilation problems that we may run into. This is real world practical situation you can run into in the back of the ambulance. Obviously, we do a lot of tracheostomy transports, and it would be real easy for one of these to become dislodged or obstructed. So let's talk about how we're going to deal with those situations. The first thing that we would recognize if the patient's on the ventilator, you'd start getting high pressure alarms. You could also start getting high PEEP alarms, disconnect alarm. The big indicator is going to be end-tidal CO2 that's starting to drop off. You're starting to have end-tidal CO2 waveform capnography problems. Whenever those are happening, immediately start your dope mnemonic. With the equipment, also assure when you do your changeover that you're using pro-transport end-tidal CO2 equipment and our monitoring stuff. You assure we've checked that, we know how it operates, and you're good to go. Our very first thing we'll do is go through the dope mnemonic, displacement, obstruction, possible pneumothorax, and then equipment failure. We would start by putting the patient on high flow oxygen with a non-rebreather mask or a nasal cannula at 15 liters. We would disconnect our circuits. Then we would try to ventilate through our tracheostomy to check for compliance, check for obstructions. At this point, if I'm meeting resistance or I have a compliance problem, the next step, we're going to try to pass a suction catheter through the airway. We try to suction. Next step, try to rebag the patient to see if we have any improvement. If there's no improvement, next step, switch out the inner cannulas. We'll take the inner cannula out. We'll grab a new inner cannula, rotate that in. Again, try to ventilate the patient. We still have an obstruction. We're still not able to ventilate the patient. Next step, deflate the balloon. Remove all caps, any other accessories that may be attached to the tracheostomy. We're deflating the balloon. We're removing the inner cannula. We can try to ventilate directly to establish. Okay? If we're still having problems at this point, next step is to change out with a smaller unit. I know when I worked critical care, we would always have one size smaller at the bedside. Best practice would be if you're picking up those patients from critical care or ER, make sure you're obtaining one small smaller obturator assembly to carry with you for the transport. What we're about to do can only be done on well-established trachs. Do not do this if the trach is less than 7 days old. This is only if greater than 7 days and there's no retention sutures on the side or stay sutures. It's only for well-established trachs. So over 7 days, we'll do a change out, rotate out with the next size smaller. Here's our smaller tube. We have the introducer already in place. We lubricate it and put it into the well-established stoma. Pull our obturator out. We'll grab our inner cannula. And attempt ventilation. One thing you'll want to be careful of is as you're inserting the next smaller one is to make sure that you are not creating a false channel. It shouldn't be a factor if it's a well-established trach. Again, we're assessing compliance, chest rise and fall if we're able to ventilate the patient. If we continue to have a problem, the next step, we're going to remove the obturator and just go ahead and intubate the patient with a standard endotracheal tube. We'll use a flex guide bougie. We want to use the Cadet tip so that we're at the appropriate angle to enter the trachea. We'll insert the bougie into the trachea, into the stoma, until you reach hold or it snags or holds up. We take our 6-0 endotracheal tube, thread that down. And then as soon as you just meet resistance, we will inflate our balloon. Remove the bougie. Begin to VAG our patient. Once we have compliance, we have good chest rise and fall. The next step would be to attach end-tidal CO2 monitoring. Make sure that we have a good end-tidal CO2 waveform, and then proceed. So that would be your rescue for tracheostomy. Bink. Next thing we'll move into is, in the event the endotracheal tube fails, we're not able to intubate the trachea, we're not able to get the bougie in, and we're left with obturators that don't work. The last fail-safe, we can intubate directly over the stoma with an infant mask, and we'll grab an assistant to help. So my assistant will bag the patient and I'll secure over the stoma. So we can directly bag over the stoma, just like this. And then if there's anatomical problems or seal problems, the next step would be to grab an iGel Airway. These can seal against the skin a lot better. And then my assistant can ventilate, and we can use an iGel directly over the stoma. Again, this is just for demonstration, but our bag valve mask would be attached to high flow oxygen during this time, and we would be ventilating. We're now looking for chest rise and fall and checking to see if we can get our SpO2 rising.